Isoenzymes are those enzymes which are functionally similar, means they catalyze the same reaction, but their origin or source-wise they are different. Source-wise they are different. Are important tools for diagnosis as well as prognosis. If they are originating from different tissue, then which tissue gets affected, we can make out by measuring that particular isoenzyme form. Say for example, amylase. Amylase has got, there are two types of amylase. Salivary amylase and pancreatic amylase. So if there is a disease related to salivary gland, then the salivary amylase component will increase, and if there is disease due to pancreas, then pancreatic form will increase. Now whenever we say the different forms, there comes how do we detect them. The different isoenzymes can be detected in many ways, depending on their physical properties or chemical properties. Physical properties means whether they are heat stable or they are inflammable, beyond certain temperature. Say, for example, alkaline phosphatase. It has got two isoforms. One is heat stable beyond 65 degrees Celsius or at 65 degrees Celsius, but another form is heat labile at 65 degrees Celsius. But some are different in their amino acid residues. Say for example, CKMP. They can be differentiated by electrophoresis. They can be differentiated by chromatography. Correct? They can be differentiated by their interaction with specific inhibitors. Their specific inhibitors. Likewise, there are many ways by which we can measure. Now, here comes another term called non-functional enzymes. Once it was asked in the first talk, what are defined non-functional enzymes? Give examples. Non-functional enzymes means the enzymes whose natural substrates are missing. Where? Remember, whenever we don't mention anything, the source, the location, it is blood. We say that blood is a picture of human health. So we get everything from the blood. Whatever enzyme is available, which is not available, is increased. Now, there are certain enzymes whose naturally occurring substances are present in the blood, and there are certain enzymes whose naturally occurring substances are not present in the blood. But why do we find them there? Because of tissue damage. And tissue is damaged, that's why it has been poured into blood. The enzyme has appeared in the blood due to tissue damage. So it detects some tissue has been damaged, that is why that enzyme is available in the blood. Whereas there should not be present there. Why? Because there is no natural substrate for that enzyme. These enzymes are called non-functional enzymes. So actually non-functional enzymes are clinically more important than functional enzymes. Why should they be there? What is the reason? Key কারণে তারা থাকবে ব্লাডে। কারণ নেই। কারণ হচ্ছে দুই রকম কিছু ড্যামেজ হয়। লিভার খারাপ হলে লিভার এনজাইম আসবে, প্যানক্রিয়াস খারাপ হলে প্যানক্রিয়াস এনজাইম আসবে, হার্ট কার্ডিয়াক মাসল খারাপ হলে কার্ডিয়াক এনজাইম আসবে। এর উপর ভিত্তি করে আমরা এই ডিজাইনটা করি। Now, how the tissues release the enzyme? Tissue can release the enzyme in different ways. One, due to certain change in the atmosphere, internal milieu of the body, the porosity of the tissue membrane is altered. It's called leaking, normal leaking. If we measure AST and ALT in the blood, AST and ALT, these two enzymes, they are both non-functional enzymes. They both are related to liver diseases, but usually for a normal person, it is found in the blood with a very nominal value, so 5 to 40 units per liter. What does it mean? Liver is always sick? No. That means it's a normal seepage. Normal seepage or leakage. Normal seepage or leakage. It has nothing to do with the disease state of the tissue. Clear? Whenever the tissue gets damaged, the amount of enzyme poured into the blood is directly proportional to the extent of tissue damage. Am I clear? If the tissue damage is less amount will be poured into blood. If tissue damage is more will be there. Now, there are other two terms called chronic and acute. What is chronic and what is acute? Acute means immediately after the tissue damage, the levels are increased. Levels remain increased for prolonged period, moderately high, not very high, but moderately high. That means he is suffering from a chronic disease which is laying off some or other part of the tissue now and then. থেকে থেকে টিস্যুর কোনো অংশ খারাপ হচ্ছে। For example, a continuous drinker means who drinks alcohol will show moderately high elevation in GDT. A sudden drinker, normally who don't drink much, but one day he drank too much of alcohol. Next day the GDT spike will be much more higher than the chronic drinker. Understood? Now, reasons for enzyme is leakage in the blood, leakage cell damage, cell death, hypoxic. It could be from hypoxia, it could be from intercellular toxicity, alcoholic liver disease. The example of intracellular toxicity, hypoxia, AMI, myocardial infarction, hepatic infarction, renal infarction. These are hypoxic disease for tissue damage. Organ specificity, they are originated from the particular tissue, but they are not always so. Example, AST. AST is such kind of enzyme which should be present, which must be present, and which is present in all tissues. But then AST is predominantly measured in the laboratory in order to relate with liver disease or cardiac disease. How do you ascertain that its elevation of AST level is due to cardiac disease or liver disease? We don't know. We can't do that. We need to take help of other enzymes in addition to AST. Clear? Both AMI or acute myocardial infarction or liver disease will show increase in AST level. But that is not true to identify which organ is affected. We may not be right always. Time course of disease. Time course of disease. When you start with understanding of clinical embryology, we always tell you that in this disease such and such enzyme will increase. In this disease such enzyme will increase. Can we see that in any liver disease all the liver enzymes are decreased? Is it possible? The person is suffering from liver disease, but all the liver enzymes are down, almost zero. Is it possible? What do you say? What is the common sense tells you? Yes or no? Possible? Can you cite one example? Serosis of liver. What is serosis of liver? irreversible change in hepatic parenchyma or hepatic architecture. Irreversible change, which cannot be buried back. Usually liver is such a tissue which can regenerate itself. But in this case, you see, it is irreversible. So that line is important. It is irreversible damage to hepatic architecture. That tells everything. Means parenchyma disease, etc., etc., everything. Now, when cirrhosis begins, sets in, all the enzymes will increase. When cirrhosis will come to terminal state, there is no single healthy hepatic cell is alive to produce AST or ALT. So, blood will show zero AST, ALT, GGT. As you see, that critically ill, terminally ill patient suffering from liver disease will show no elevation in AST, ALT. Zero, comes zero. Why? Because none of the cell is alive. All the cells of liver are dead. Usually, patient never come back to correct the report, this kind of report. Why? They need not to. They have reached. Whenever we receive such kind of diseases, like say for example cholesterol level, it comes very low, around 10, 12. You don't have to wait for next day. He will never come back. Many times it happened, we ask for a repeat sample, but the answer came, patient is expired. Right? Like this. It happens. So this is one of the reasons. So this will show the time course of disease. It will be increasing, then abruptly fall. Why? Because no other tissue is living in the. Now, this is a quick look about the enzymes which we use for what kind of diseases. AST and ALT. This is the old name. This is the modern name. Aspartate, amino transferase. Please check what is the name, actual name. Aspartate amino transferase, not aspartate transferase. Aspartate amino transferase, not aspartate transaminase. Right? Serum glutamate oxalate transaminase. Follow? Clear? So this T and that T are not same. So this is old one, old name. This is new name. AD and SGPT. Serum glutamate pyruvate transaminase. This is more about liver, not heart. This is heart and liver. Alkaline phosphatase. Suppose this kind of question we asked. List out the clinically important enzymes and the organ involved. So just name it. And which organ they are related to. Alkaline phosphatase, ALP, bone, intestine and other tissues. Acid phosphatase, prostate, GGT, gamma glutamine transferase or gamma glutamine transpeptidase. Gamma glutamine transpeptidase. Actual name is transpeptidase. CT, creatine kinase. Skeletal muscle, brain, and cardiac muscle. Lactic deaminase. It is present in all tissues. Heart, liver, muscle, skeletal muscle, RBC. Alpha amylase found in pancreas. Alpha amylase. Another form is here, salivary amylase. Alpha amylase is found in two forms, salivary and pancreas. But we use alpha amylase for detecting pancreas disorders. Now here one point can be illustrated that amylase alone may not give you idea about the disease of pancreas, we need to perform a test for lipase activity. Lipase is more specific toward pancreatic disorder compared to amylase. In order to find hyperamylasemia related to pancreatic disorder, we need to rule out any contribution by cerebral gland. How? By clinical examination. So suppose amylase and lipase both are elevated. Means what? Disorder related to pancreatitis. Right? If only amylase is high but lipase is normal, then it is due to cerebral glands. Like inflammation of the carotid glands. Right? Now, most important marker infection are enzymes related to cardiac markers. Here, there are two classes. One is cardiac enzymes, another is cardiac markers. When you say only cardiac markers, it encompasses cardiac enzymes plus certain proteins. When you say cardiac enzymes, we are left with only these three, right? Others are not enzymes, they are proteins, they are markers, but they are proteins. So, what do you call them? Acute phase proteins. These enzymes are also active phase proteins, but they are enzyme in nature. But those are active phase proteins which are not enzymes. For example, TROP-T, troponin T, troponin I, myoglobin. These are also marker for AMI, acute myocardial infarction. But they are acute phase proteins, they are not enzymes. But these are cardiac markers or cardiac enzymes. But they are only cardiac markers, they are not enzymes. So when we ask question like cardiac enzymes, be very careful. We want you to write only these three. When we ask cardiac markers, then you add troponin I, troponin T, myoglobin, etc. You can add. Depending on your base of knowledge or knowledge of your neighbor. Now, individually these enzymes can be asked. A short question, individually. Give the clinical importance of stearin kinase. Now, one question was asked after the first internal. Name one compound which is formed by 3 amino acids in 3 organs. No one could answer. This is creatine. It is made up of 3 amino acids. What are those? And methionine, sand. Right? 3 organs. Liver, kidney and muscle. Right? So this is like this, you should remember. People ask questions like this. So creatine kinase, what does it do? Reaction हो जाएगा. So creatine kinase is an enzyme which converts creatine phosphate to creatine or creatine to creatine phosphate. Both sides. It depends on the pH of the medium, in which direction will move on. It breaks down creatine phosphate to produce creatine, usually, normally. Okay? Why? Because in muscle, the energy currency is not ATP, it is creatine phosphate. Right? So without creatine phosphate, muscle will attack. And if muscle is damaged, then which portion will be poured into or expelled into blood? Creatine kinase. Right? Creatine we cannot measure. Why? They are close related, they relate to some other disease like kidney. So what we are left with? We are left with only the enzyme getting kinase. So whenever there is a damage to the muscle, this particular enzyme will increase the blood. Now whenever this cardiac marker is asked, you need to remember 3 stages. 1. How soon they appear in the blood after the trauma incidents or traumatic incidents or tissue damage. How soon? Number 2. When they reach the maximum, means maximum amount of enzyme. Number 3. When they come back to normal. First is, number 1 is how soon they appear in the blood after tissue damage. What is it here? 0 to within 6 hours. Total CK reaches the peak within 1 to 2 days and comes back to normal. Right? So for total CK when you are measuring, then we need to remember, we need to address these 3 points. How soon they appear in the blood, when they reach, how long it takes to reach the maximum, and by which time they come back to normal. Clear? Why these 3? This will help us to assess the staging of the disease. Staging of the disease. A patient comes with elevated CK. You can't make out when he had the attack. If it is normal, by seeing the level, suppose it is elevated, but we cannot tell that whether he had it very soon, or yesterday, or 2 days back. Right? If we don't know about these 3 points, so it starts increasing within 6 hours of MI. How do you know this MI? The patient will never come and say, Dr. Sahab, I am suffering from MI. What do you say?
Pain.
Chest pain. Okay, you will not even say angina pectoris, you will say chest pain. Not even that, you will say chop heaviness, short of breath. This they will get. Right? So you measure CK. This is the most immediate marker for MI. If it comes after 2 days or 3 days, you might miss the event. You can't make out by CK estimation that he has suffered from cardiac attack. For that, some other enzymes are there. Serum AST, more slowly, maximum activity within 48 hours. By the time CK comes to normal, AST reaches the peak. So it is much more slower. So the patient, suppose he is the harvesting time. The patient suffered from chest pain, took some rest, and completed the harvesting. After 3 days, putting all the weights in the grenadine. Now we have time to come to see the doctor. After 4 days. How do you know? Which enzyme you test for? CK? No. CK should have been normal by that time. Only AST and LDH you are left with. Okay? So no significant elevation of LDH seen for the first 24 hours. It reaches maximum at about 3 days and remain elevated for 1 week. 8 days. Almost 8 days. So, first 24 hours, it starts increasing, which is peak by 3rd day, 72 hours, and comes back normal by a week. This enzyme is little bit non-specific to myocardial tissue. Right? It may be due to liver disease, আচ্ছা আগে পরে আসবে ইংলিশে এখানে শুনে রাখবো ইংলিশে বললাম ইংলিশের বাংলা নম্বর কোনো দিন লাগে আচ্ছা এবার liver disease types of liver disease hepatic necrosis hepatitis cholestasis jaundice hepatocellular damage কোনটা কেমন কি আছে জানতে চাও বলো এটা মানে নেক্রোসিস মানে dead tissue is dead some maybe for any reason hypoxic necrosis hepatitis is what it is not dead but irritated inflamed cholestasis nothing wrong with the tissue with the drainage system the biliary duct itself is blocked intrahepatic or extrahepatic jaundice symptom showing elevated serum elevated hepatocellular damage mostly by viral hepatitis now these liver enzymes are used as a tool for detection of type of jaundice. By this time, I think you should know there are three types of jaundice. One is pre-hepatic, hepatic or hepatocellular, and post-hepatic. One is for overproduction of bilirubin. Another is for obstruction. Third one, middle one, insufficiency in conjugation process. Hepatocellular jaundice is due to insufficiency in conjugation process. These three reasons. Fine. So these enzymes we will see A, differential diagnosis of jaundice 1, and B, monitoring of drug toxicity. The patient is undertaking some medicine. You should know whether this is working or not. How do you know? So, for prognostic purposes, we use two uses, diagnostic and prognostic. These enzymes are more prevalent for prognostic purposes. So better used for prognostic purposes. ALT is more specific than AST for liver disease. Hepatocellular disease has only modest effect on ALT and DGT. Its damage to the hepatic tissue itself, it will not show much DGT or ALT. Why? ALT location is intestine, so giving the duct, and DGT is particularly due to alcoholic liver diseases. All sources are not due to alcohol. In cholestasis, higher values of ALT and DGT due to synthesis, but ALT increases more than DGT. Okay? Cholestasis means another enzyme you might find 5' nucleotides that also increases due to cholestasis process. Now, how do you determine that this elevation is showing some disease condition or going to have a disease condition? How do you know? Is it progressive or static? How do you know? There are these values, people have worked for it, research, that these values, if they are 3 to 5 times than the normal levels are termed as LRL and URL. LRL means lower reference level, URL means upper reference level. When you say the normal range for AST is 5 to 40 units per liter, that means 5 is LRL, lower reference level, and 40 is upper LRL and URL মাত্রা। তা মনে করো সাপোজ আমি বললাম AST লেভেল একটা পেশেন্ট দেখলাম আমি 120, আমি কি বলছি সুজিস হয়ে গেছে সুজিস This has 3 times. 40 is highest, you are 3 times than you are. No. If ছোট্ট জ্বর হয় তাহলেও বাড়তে পারে। There are many fever conditions in which these will increase. When it is 10 to, when the disease particularly occurs in the liver, it will increase by 10 to 15 times. So how much is 10 times of 40? 400. It has to cross at least 400 for you to diagnose it as a disease condition. Remember. Fine? How much we get? The real disease, liver disease patient. 1,500, 2,500, 3,500, like this. Right? So, you should know that how much it is increasing. 3 to 5 times increase in any enzyme doesn't show that it is related to the disease. At least it should be increasing. Calls for higher serum ALC levels. Liver disease are these, cardiac disease are these. Find these two are commonly used. These are less commonly used, but still they are the reason for high ALC level. Skeletal muscle injury, crash injury, trauma or myopathy or hemolysis. So how to differentiate is due to MI or due to hemolysis? If it is due to MI, it will increase by 10 to 15 times. If it is due to hemolysis or this kind of disease, it might not be increased that high. Clear? ALP. Therefore, ALP is related to bones and intestine. Right? Bones means usually if there is obstruction in the small in the biliary duct, intrahepatic or extrahepatic, the ALP level will increase. Any disease related to alimentary canal, ALP might increase. And bone require alkaline phosphatase. For what purpose? For deposition of calcium hydroxyapatite in the bone. So the people who are growing, means children, growing age, they will have high ALP level. What about pregnancy? See, 3rd trimester, the normal pregnant lady will show elevated level of ALP. Why? Because by 3rd trimester, the bones of the fetus are started being formed. Right? So that's why ALP level is increased not due to because of our own, because of the fetal growth. So pregnancy and growing children, they will show elevated level of alkaline phosphatase. But from that, you must not diagnose it as obstructive jaundice. It should be supported by other parameters and above all, clinical examination. Right? Quickly jot down or go through it about alkaline phosphatase. See the optimum pH between 9 and 10. Activated by magnesium and manganese ion. Involved in bone calcification and absorption and transport of nutrients from intestine. Okay. Produced by osteoblasts. Osteoblasts means the juvenile bone cells. Juvenile bone cells. Right? And osteoclast means senile bone cells. Right? Medical is full of terminologies. Now here, like the different isoforms of alkaline phosphatase. It's up to you how much you can remember. At least 3 forms you remember. ALP1, but by 56 or 65 degrees Celsius. Heat level and heat resistance. Heat level and heat stable, these two form, which is inactive above 60 degrees Celsius and which is active active beyond 65 degrees Celsius. These two levels. Another is Reagan isoform. Reagan isoform is named after the patient in whose body it was found first. His name was Reagan. Hence the name Reagan isoform. Another is placental. এটা নিতে পারো, এটা একটা সিএমএল একটা লিম্ফোমা ক্ষেত্রে এই একটা মার্কার অ্যাকিউট ফেজ প্রোটিন সিএমএল লিম্ফোমা ক্ষেত্রে এটা আছে যে ইনিশিয়ালি পেশেন্ট কোনো থাকে with no such symptoms at all, but ALP always remains moderately high. So when you go to a general practitioner, general physician, so he sends the case back to the specialist, hematologist, and then hematologist will diagnose this one. Report. Fine. Heat stable form is the placental origin. Placental origin. A pregnant lady showing elevated level of ALP2. See, everything, whatever I have written, any gap book has given every information. Maybe more than this. But what is important, what we need to emphasize on, what is the way of approaching to the chapter, that is what should be taught by a teacher. We will let you know what to read, what not to read, more importantly. How to read, how much to read, up to you. Fine. ALP2, the heat stable form or placental origin. This was an old method to distinguish between the elevation of ALP due to pregnancy or obstructive jaundice. Can it happen that pregnancy and obstructive jaundice taking place simultaneously? Yes, how to differentiate? No way. This was the way previously. Nowadays, USG is there. Nowadays, USG is there. So, this is pre-USG era. This is how they used to differentiate. If the maximum activity of the placental of the ALP is gone, that means it is heat labile. It is due to obstructive jaundice. If nothing is much changed, only 10% is changed, this is how much? 10% of all ALP. And this is nothing is mentioned. But this will increase when? If it decreases by more than 10%, the total value, by boiling above the 65, that means this is due to this one. But if it doesn't change, less than 10%, then what? This is a heat stable form of alkaline phosphatase. This is a placental origin. So we make up this elevation is due to pregnancy, not due to obstructive jaundice. Pre-USG era diagnosis. Now it has no meaning. Most of the 90% lab will not know this classification. Fine. The list of diseases related to ALP elevation: physiological, infancy, puberty, pregnancy, discharge, bone disease, hepatobiliary disease, and others, carcinoma of bronchus. This is ectopic production of alkaline phosphatase. Ectopic production of alkaline phosphatase. In this case, ALP is termed as acute phase protein. ALP is termed as acute phase protein. ACP, usually related to prostate enlargement, prostate cancer. Is there any other marker for prostate enlargement? Everyone knows PSA, prostate specific antigen. Is specific prostate hormone is so it is not always specific. It is not always specific, right? So sometimes it might increase, sometimes it might not. Amylase. T type, S type, and intestinal malignancy. This is no type, but it increases of cancer only. It is neither P type nor S type. S type means salivary gland. It means pancreatic type. Diagnosis and monitoring of pancreatitis. Take full permission. Most of the patients do not survive pancreatitis. If you survive, that means you are lucky to go. Lipase increases within 2 to 12 hours of acute attack. Pancreatitis usually show up with acute abdomen, very acute pain. Immediately after the pain, if you estimate lipase which increase, that means it is due to pancreatitis. It is more specific type of pancreatitis than amylase. These are the important lines. ALP, cholesterol and bone disease, diffusion by elevated bilirubin and transcendent level in cholestasis. These lines just go through and tell me whether you have understood or not. This one, AST may be high due to MI or hepatitis, so it makes confusion between diagnosis of confusion in diagnosis. We confirm by LDH, that means what? If LDH and AST both are elevated, then that means it is due to MI. If LDH and AST both are, no, not both, LDH is normal, then it is due to hepatitis. If so, we will see later. We will complicate it furthermore. Looking so easy, na? But it's not so easy. Anyway, ALP, cholesterol and bone disease. How to differentiate? Perform GDT, perform bilirubin test. If bilirubin is elevated and ALP is elevated, that means it is due to jaundice due to obstetric causes. But GGT is due to normal, that means it is not due to liver. High, that means due to liver cause. Bone disease GGT will not increase.
In the dissected body, open the and clear the greater omentum and other parts, we show the liver. So we have taken many. Sagittal section, again a right-sided sagittal section, right? In this way I am seeing, not in this way. So this is the posterior side, this is the sacrum and coccyx, and here is the diaphragm. Here is the diaphragm, right? Liver is cut in this fashion. This is the liver. Right? This is the liver, and underlying it, this is the gallbladder. So when you view this in sagittal section, you will see on the right side there is a transverse column. And above the transverse column, there is a kidney and suprarenal gland. Again, I have a view from here. I have as a cadaver lying on the table and cleared the heteromentum and other transverse muscularis, etc. So we see the liver, right? here is the diaphragm. Here is the ascending colon, the transverse colon, and the descending colon. Now, you can insinuate অর্থাৎ হাতটা ঢোকাতে পারি এরকম ভাবে ডায়াফ্রামের কাছে over the liver, over the anterior surface of the liver. It is possible তো যে আমরা এখানে লিভারটা পড়ে রয়েছে একটা বডিতে, আমরা এখানে হাতটা ঢোকাচ্ছি এবং we can reach more or less. Can you touch the diaphragm? No. Why we cannot touch the diaphragm? Because again, go to my first class or second class, you will find that's peritoneum reflection. Peritoneum reflection. There is a peritoneal reflection. So, and this is known as the superior layer of the coronary ligament. On the back side, there is an inferior layer of the coronary ligament. Peritoneum is reflected to the diaphragm from here, leaving a triangular area uncovered by the peritoneum. So this area is uncovered by the peritoneum because peritoneum covering the anterior surface of the liver, and here it is reflected to the diaphragm in this fashion. So it raises a fold. ভালো করে দেখো, এখান থেকে peritoneum cover করছে visceral layer, then not going totally to the superior border. It is reflected here and goes to the diaphragm, and this layer we call the superior layer of the coronary ligament. Similarly, on the back side, on the posterior surface, another layer is reflected on the back side to the diaphragm. So there is a two layer. Look, there is a superior layer and the inferior layer of the coronary ligament, leaving a gap which is part of the liver, which is not covered by the peritoneum. And this is known as the deep beer area of the liver. Deep beer area of the liver. Look, this is covering and is reflected onto the diaphragm, a single layer of peritoneum. We call it this layer superior layer of the coronary ligament. On the posterior surface, another layer is reflected onto the diaphragm, and we call it the inferior layer of the coronary ligament. So there is a part of area which is not covered by the peritoneum, this area, and both the superior and inferior layer join on the right side and form a single ligament. We call it the right triangular ligament. We call it the right triangular ligament. On the base of the, this is the inferior layer, this is the superior layer, and the base here lies the inferior vena cava. So if you one ask you what is the boundary of the deep beer area of the liver, sir, superior layer of the coronary ligament, inferior layer of the coronary ligament, base is formed by the inferior vena cava, and apex is formed by the right triangular ligament. So this is the beer area of the liver. Now what happened? If you inside, so actually it is better seen in the depot, in the dissection hall. So it is very difficult to understand here, especially you. So it is the superior layer, this is the inferior layer, and here is the inferior vena cava, right? And now, so when you inside with the hand, it cannot go above because of the superior layer of the coronary ligament, right? Now, so in this way there is a space between the this is the anterior abdominal wall. ভালো করে দেখো, this is the, now এটাকে আমি এখন anterior abdominal wall বানাচ্ছি. So এরকম ভাবে ছিল, so it is the anterior abdominal wall, so you can insert a space between the liver and the anterior abdominal wall, and both are covered by the peritoneum. The anterior abdominal wall is covered by the parietal layer. On the liver side, it is covered by the visceral layer of the peritoneum. So there is a space anteriorly which is covered on all sides by the peritoneum. Similarly, this is the inferior border of the liver. This is the inferior border of the liver. You can slightly lift up the liver and you can push your finger under the inferior surface of the liver. You can. So there is a space posterior to the inferior surface and posterior surface of the liver. So there are two spaces you have to understand now. One is anterior to the anterior surface of the liver. One is posterior to the inferior surface of the liver. And both these spaces are covered by the peritoneum. And there is another space which is known as the deep area of the liver. তাহলে তিনটে স্পেস জানতে পারলে, একটা anterior space, একটা inferior border থেকে হাত ঢুকাচ্ছ, পেছনে যাচ্ছ, সেটাকে বলা হচ্ছে posterior space, both are peritoneum, এবং এই স্পেসটা কিন্তু নন পেরিটোনিয়াল or extra peritoneal. তাহলে রাইট সাইডে আমরা তিনটে স্পেস পাচ্ছি, anterior intraperitoneal space, posterior intraperitoneal space and extraperitoneal space. এবং এইখানে আমরা পড়েছি একটা লিগামেন্ট আছে, তাকে বলা হয় falciform ligament, and all this space is on the right side of the falciform ligament, right? Similarly, on the left side also there is a space anteriorly, there is a space under the inferior surface or posteriorly. Similarly, এইখানে আরেকটা স্পেস রয়েছে near the stomach. স্টমাকও একটা বিয়ার এরিয়া রয়েছে, সেখানেও একটা স্পেস রয়েছে, তাকে বলা হয় extraperitoneal স্পেস। ইম্পর্টেন্ট নয়। তাহলে আমরা কি কি শিখলাম এখানে? রাইট সাইডে মানে রাইট টু ওয়ান, রাইট টু দ্য falciform ligament, এটা হচ্ছে রাইট সাইড, এটা হচ্ছে লেফট সাইড। কে ডিভাইড করছে? falciform ligament। রাইট সাইডে কি কি স্পেস রয়েছে? intraperitoneal space, extraperitoneal space। intraperitoneal space আবার দুটো, কি anterior intraperitoneal space, right anterior intraperitoneal space, right posterior intraperitoneal space, আর extraperitoneal space একটাই, সেটা হচ্ছে deep ear area of the liver। Similarly, left side এর হচ্ছে left anterior intraperitoneal space, left posterior intraperitoneal space, and left extraperitoneal space। তার মানে 6টা স্পেস দেখতে পাচ্ছি আমরা, কেমন 6টা স্পেস দেখতে পাচ্ছি। এই 6টা স্পেস is under the diaphragm, সব মিলিয়ে তাকে আমরা বলি subphrenic spaces। That's important in your clinical practice। subphrenic spaces কি বলা হয়? subphrenic spaces। তাহলে subphrenic spaces কটা রয়েছে? 6টা। কিভাবে তাহলে এটা ভাগ করছি? subphrenic space, কেন subphrenic space বলছে বলো দেখি? কেন subphrenic space বলছে? phrenic কথাটার মানে কি? diaphragm। sub মানে হচ্ছে below, এগুলি সবকটাই হচ্ছে below। তার মানে subphrenic space দুটো, একটা হচ্ছে রাইট, একটা হচ্ছে লেফট। রাইটের আবার দুটো, intraperitoneal, extraperitoneal। লেফট এর আবার দুটো, intraperitoneal, extraperitoneal। interperitoneal আবার দুটো, anterior and posterior। interperitoneal আবার দুটো, লেফট এরও anterior and posterior। এই posterior intraperitoneal space on the right side এর নাম হচ্ছে hepatorenal pouch of Morrison। অর্থাৎ লিভারের ডান দিকের তলে যদি হাত ঢোকায় তাহলে আমরা যে স্পেসে পৌঁছাবো সেই স্পেসটার নামই হচ্ছে hepatorenal pouch of Morrison। আমরা লিভারটা এইটা ধরি, লিভার রয়েছে, এইটা লিভার, এটা লিভার, পেশেন্ট এরকম ভাবে শুয়ে আছে মাথায় দিকে, আমি দেখছি অথবা তোমাদের দিক থেকে দেখায়, এটা লিভার, এখানে ডায়াফ্রাম, কেমন, এটা ডায়াফ্রাম। এবার আমি হাত ঢোকালাম, এই স্পেসটার নাম কি, রাইট সাইডে যদি ঢোকাই, রাইট অ্যান্টেরিয়র ইন্ট্রা পেরিটোনিয়াল স্পেস। ইন্ট্রা পেরিটোনিয়াল কেন, সব দিক দিয়ে কভার বাই পেরিটোনিয়াম। এবার লিভারের তলে যদি হাত ঢোকায়, রাইট posterior, very good, intraperitoneal space। তার আরেকটা নাম কি, hepatorenal pouch of Morrison। সুতরাং লিভারের ঠিক পেছনে হাত ঢোকাচ্ছি, মানে আন্ডার দ্য লিভার hepatorenal pouch-এ হাত ঢোকাচ্ছি। hepatorenal pouch-এর যে হাত ঢোকাচ্ছি, হাতের ডরসামে রয়েছে লিভারের ইনফিরিয়র সারফেস, যেমন, আর নিচে রয়েছে পেরিটোনিয়াম কভার্ড কিডনি, suprarenal gland and right colic system। এই এখানটায় যে হাত ঢোকাচ্ছি, ঠিক লিভারের, তোমার লিভারের ইমপ্রেশন মনে আছে, রাইট সাইডে রেনাল ইমপ্রেশন রয়েছে, এই রেনাল ইমপ্রেশনে হাত ঢোকাচ্ছি। তার মানে হেপাটোরেনাল পাউচের, এবার নিজেরা বলো অ্যান্টেরিয়র বাউন্ডারি কি, এই আবার বলেছি অ্যানাটমি কিন্তু সমস্ত বাউন্ডারি বিচার হবে কোন মানে অবস্থায়, অ্যানাটমিক্যাল পজিশন। সুতরাং এটা কিন্তু অ্যান্টেরিয়র হয়ে গেল, সুপিরিয়র নয়। কিন্তু আমি যখন ডেড বডিকে দেখছি, ইট ইজ সুপিরিয়র, বাট ইন অ্যানাটমিক্যাল পজিশন ইট ইজ অ্যান্টেরিয়র। সুতরাং এটা ভাববে না সুপিরিয়র। তাহলে অ্যান্টেরিয়র পজিশনে অ্যান্টেরিয়র বাউন্ডারি কি, ইনফিরিয়র সারফেস অফ দ্য লিভার। কোথায় গিয়ে হাতটা আটকেছে, সুপিরিয়র বাউন্ডারি, ইনফিরিয়র লেয়ার অফ দ্য করোনারি লিগামেন্ট। আটকাবে উপরে সুপিরিয়র, ডায়াফ্রাম আগেই বলেছি অ্যান্টেরিয়র এবং পস্টেরিয়রে রিচ করতে পারে না ডিউ টু দিস লিগামেন্ট। তাহলে যদি হেপাটোরেনাল পাউচ অফ মরিসন মুখস্থ করার কোনো দরকার নেই, ডোন্ট নিড টু ক্র্যাম, জাস্ট ইউ আন্ডারস্ট্যান্ড দ্যাট anterior boundary is the inferior surface of the liver, posterior boundary কিডনি, কোন কিডনি কমপ্লিট করলাম কি, রাইট কিডনি। এটা বলতে হবে, লেফট কিডনি নয়, বিকজ ইট ইজ অন দ্য রাইট সাইড। তাহলে রাইট কিডনি, রাইট সুপ্রারেনাল গ্ল্যান্ড, আর যদি বাস রাইট কিডনি, রাইট সুপ্রারেনাল গ্ল্যান্ড বলে দেব। উপরে কি আটকাচ্ছে, ইনফিরিয়র লেয়ার অফ দ্য করোনারি লিগামেন্ট। আর নিচে কি হচ্ছে, এই স্পেসটা, এখান দিয়ে স্পেসটা, but দুটো জিনিস অলরেডি ইউ হ্যাভ সিন ইন ইওর ডিসেকশন ক্লাস। এই যে অ্যাসেন্ডিং কোলন, এটা অ্যাসেন্ডিং কোলন, এটা ডিসেন্ডিং কোলন। এইখানে মনে করছি এই জায়গাটা একটুখানি ডাউন আছে, এরকম চ্যানেলের মতো আছে, এইটা পাশে একটু চ্যানেল আছে, এইখানে একটা চ্যানেলের মতো আছে। এই অ্যাসেন্ডিং কোলনটা এরকম ভাবে থাকে, ধরো ইট ইজ অ্যাসেন্ডিং কোলন, এই জায়গাটা একটা গর্ত, এইরকম একটা ডাউন একটা চ্যানেলের মতো আছে, এখানে একটা চ্যানেলের মতো আছে। দিস ইজ অ্যাসেন্ডিং কোলন। এর পাশে একটুখানি দেখবে চ্যানেলের মতো আছে, বেশ এরকম গাটারের মতো, এটাকে বলে রাইট প্যারাকোলিক গাটার। আর লেফট সাইডে সিমিলারলি রয়েছে লেফট প্যারাকোলিক গাটার। তাহলে যদি হেপাটোরেনাল পাউচ অফ মরিসনে কোনো পাস অ্যাকুমুলেট হয়, if there is an accumulation of pus in the hepatorenal pouch of Morrison, patient যখন দাঁড়িয়ে পড়বে, সেই পাসটা এখান দিয়ে নেমে এই প্যারাকোলিক গাটার দিয়ে নেমে চলে এসে ইভেন পেলভিসে চলে যেতে পারে, তাহলে এত পড়ানো হচ্ছে কেন, হেপাটোরেনাল পাউচ অফ মরিসন, হেপাটোরেনাল পাউচ অফ মরিসন। এগেইন বলছি, patient in supine posture In supine posture, supine মানে কি পেশেন্ট এরকম শুয়ে আছে, ভালো করে শোনো। In supine posture আগে একটা টার্ম শিখিয়েছিলাম ডিপেন্ডেন্ট পার্ট। ডিপেন্ডেন্ট মানে কি মোস্ট সবচেয়ে নিচু লেভেল যেটা তাকে বলা হয় ডিপেন্ডেন্ট। In supine posture hepatorenal pouch of Morrison is the dependent part of the body. সুতরাং পেশেন্ট আমরা কোথায় ডিল করি? হসপিটালে পেশেন্ট বেশিরভাগ সময় বেড রিডেন। সুতরাং if you suspect some patient having with a fever, no, you are not finding the cause of fever, there might be one of the cause, there must be pus accumulated under the diaphragm in the subphrenic space. So if there is a small amount of pus, if you don't think of this hepatorenal pouch of Morrison, the ultrasonologist miss the pus and the report they give him normal. But if you are cautious that there is a part where even a small amount, 25 cc, 50 cc of pus may accumulate here, they then cautiously visualize this area by his probe যেটা নিয়ে ঘোরায় এবং ভালো করে দেখলে সে ওইখানটায় বার করে দিতে পারে, otherwise he will miss. So that one of the commonest cause of unknown fever is the pus, one of which সব নয় কিন্তু ভালো করে মনে রাখবে, আমি বলেছি বলে সব ফিভারই এই হেপাটোরেনাল পাউচ অফ মরিসনে পাবে না কিন্তু। প্রথম হচ্ছে ডাক্তারের প্রথম নিয়ম হচ্ছে, মেডিকেল লাইনের প্রথম নিয়ম হচ্ছে you must think common thing first. Whenever in this era when there is a prolonged cough, you must think of tuberculosis, corona, etc. first. Then you think the unusual things, right? If there is a cough for about 1 month, not there is a gradual weight loss, you must think there is a TB. If there is an old age, you must think might it be a cancer. If there is a fever, you must think whether it is a viral fever or whether it's a whether it's a urinary tract infection. Then you think the abnormal thing. In children, you might think it is a typhoid fever. It's a young adult. So always think the common things first. So আমি বলছি বলে সব সাবক্লিনিক স্পেস ভাববে না কিন্তু আমি বলছি যখন অন্য কিছু পাচ্ছেন you must think, especially in the hospital patient, there must be operation হয়েছে, there is a chance of subphrenic space রয়েছে, and you must in your note sheet write it down so that ultrasonologist may cautious and visualize this. তাহলে কি হলো, আমরা কি শিখলাম? Hepatorenal pouch is the most dependent part of in the supine posture. Similarly, in standing posture, in case of a male, rectovesical pouch is the most dependent part, and in female, rectouterine pouch of Douglas is the most dependent part. এই তিনটে জিনিস মনে থাকবে। In supine posture, both in male and female, hepatorenal pouch of Morrison is the dependent part. In standing posture or in sitting posture, hepatorenal rectovesical pouch is the most dependent part, and rectouterine pouch of Douglas. এটা শুধু অ্যানাটমির জন্য পড়ে রাখবে না, এটা একদম মাথার মধ্যে গেঁথে নাও, সারা জীবন যেন মনে থাকে। এরপর যদি রোবোটিক ডক্টর চলে আসে তাহলে আলাদা কথা, হয়তো আসবে। আর্টিফিশিয়াল ইন্টেলিজেন্স যেভাবে উন্নত হচ্ছে, এআই, সে হয়তো আমাদের আর দরকারই হবে না, যা দেখতে পাচ্ছে দেখতে হবে। বুঝছো তো এআই? হ্যাঁ, কি অবস্থা জানো তো? আর্টিফিশিয়াল ইন্টেলিজেন্স করছো না, গুগলের সিইও পদক্ষেপ যে মানে আর্টিফিশিয়াল ইন্টেলিজেন্স সব তুমি যখন মোবাইলে সার্চ করছো, তোমার ভাবার আগে তুমি কি চাইছো বেরিয়ে আসছে না? দু একবার সার্চ করার পরে 3 নম্বর তোমাকে সার্চই করতে হচ্ছে না। কি করে হচ্ছে এটা? দিস ইজ ডিউ টু আর্টিফিশিয়াল ইন্টেলিজেন্স। অলরেডি ইট ইজ বিন স্প্রেড, যা হয়তো কিছুদিনের মধ্যে অনেক লোকের চাকরি চলে যাবে, সব মানে ইয়ে করে নেবে, ভেবে নিতে পারছে আগে থেকে। দিস ইজ নোন অ্যাজ এআই, আর্টিফিশিয়াল ইন্টেলিজেন্স। তুমি সার্চ করার আগে গুগলে তুমি এএমই সার্চ করো, সাথে সাথে মেসি চলে আসে। তুমি যদি আগে মেসি সার্চ করে থাকো, দিস ইজ দ্য আর্টিফিশিয়াল ইন্টেলিজেন্স। আমি বললাম যাকে, তাহলে এইটা আমরা শিখলাম। তাহলে আমরা যদি বাউন্ডারি বলি, এই পিকচারটা আঁকি, এই হচ্ছে হেপাটোরেনাল পাউচ অফ মরিসা। অ্যান্টেরিয়রলি রয়েছে লিভার, পস্টেরিয়রলি রয়েছে রাইট কোলিক ফ্লেক্সর, কিডনি আর সুপ্রারেনাল গ্ল্যান্ড। উপরে রয়েছে ইনফিরিয়র লেয়ার অফ দা করোনারি লিগামেন্ট, আর নিচে এইখান দিয়ে এই রাইট প্যারাকোলিক গাটার দিয়ে গিয়ে পেলভিসে চলে যেতে পারে রেক্টোভেসিকল পাউচে। সুতরাং দিস ইজ অল অ্যাবাউট দিস। এখন আমি এটা শেষ করি, নাহলে আর পেরিটোনিয়াম করে করে হয়ে গেছে। যারা যারা সার্জিক্যাল ইন্টারেস্ট তাদের জন্য এইগুলিকে আমরা রিসেস বলি, তাই তো? ইন্ট্রাপেরিটোনিয়াল যেগুলি রয়েছে, রাইট অ্যান্টেরিয়র, লেফট অ্যান্টেরিয়র, এগুলিকে আমরা উই কল ইট দ্য রিসেসেস। Hepatorenal pouch of Morrison is a one type of recess. Right anterior intraperitoneal recess, right posterior intraperitoneal recess, these are known as the recesses. Similarly, not only these recesses, this is important for pus accumulation, etc. There are surgical importance of another thing. What is that? Suppose, for example, in the duodenum, in the duodenum, this is the first, second part, third part, fourth part, but duodenum থেকে কোশ্চেন এসে গেছে, আশা করি তোমাদের আসার কথা নয়। একটা কথা দেখতে পাচ্ছ যে সাবজেক্ট কোশ্চেন is tougher than the normal general question, এটা জেনে রাখবে। সুতরাং চেষ্টা করবো ওদিকে আপনি কথাটা মাথা থেকে একদম বার করে দেবে, যে ওরা যদি পারে পাস করতে, আমি কেন পারবো? পারবেই। সুতরাং সাপ্লি ফাপ্লির ব্যাপারেই। আচ্ছা, in the duodenal recess there is some pocket of peritoneum, pouch of peritoneum, superiorly, posteriorly, inferiorly, and among the duodenal recess, তাকে বলা হয় duodenal recesses, superior duodenal recess, inferior duodenal recess, retroduodenal recess, and duodenal recess। এগুলি একটা পকেটের মতো পেরিটোনিয়াম এরকম রয়েছে। কেন বলছি এটা? পরীক্ষার জন্য তো ইম্পর্টেন্স নয়। এইটা পেরিটোনিয়াম, ধরো এটা ডিওডিনাম, এইখানে একটা পকেট তৈরি হয়ে গেছে ডিওডিনামের, এটা ডিওডিনাম, রেট্রোডিওডিনাম, এইখানে একটা পকেট তৈরি হয়েছে এরকম ছোট্ট। তাহলে ভয়টা কি? জানছি কেন? সামটাইমস কয়েলস অফ ইন্টেস্টাইন এখান দিয়ে ঢুকে গেল, যেই ঢুকে যাচ্ছে, আমরা প্রথম ক্লাসে ইমিউনাল হার্নিয়া বলেছিলাম, any protrusion of any abdominal organ or any other region, any organ through a normal and abnormal opening, সেটা নরমাল হতে পারে, অ্যাবনর্মাল হতে পারে, হ্যাঁ, তাকে আমরা বলি হার্নিয়া। তাহলে এটা গেল হার্নিয়া। এখানে জেজুনাল, এখানে কয়েলস অফ জেজুনাম এখানটায় ঢুকে গেল, তাহলে আমরা বলি ইন্টারনাল হার্নিয়া অফ দ্য অ্যাবডোমেন। ভয় কিছু না, এখানে ঢুকে যেতেই পারে, কিন্তু ধরো ছোট্ট জায়গায় ঢুকে গেলাম, প্যাচ খেয়ে গেল, তাহলে কি হলো? ব্লাড ভেসেলটাও প্যাচ খেয়ে গেল। And these are deprived of getting the nutrition, and that part of the jejunum gets necrosed, নষ্ট হয়ে যাবে, ধ্বংস হয়ে যাবে, ওই জায়গাটা ফুটো হয়ে যাবে। ফলে আমরা যা খাবো ওখান থেকে খাবার বেরিয়ে যাবে, পেরিটোনিয়ামকে ইনভলভ করবে, সিভিয়ার পেরিটোনিয়াইটিস and death is answer। সুতরাং এই জিনিসগুলি মাথায় রাখতে হবে। There are some pockets around the duodenum, not only that, posterior to the cecum also, retrocecal recess, and also along the root of the sigmoid column, sigmoidal recess। এগুলিতে কিন্তু walls of the intestine, small intestine ঢুকে, অথবা গ্রেটার ওমেন্টামের একটু পার্ট ঢুকে গিয়ে রোটেট করে যেতে পারে, তাকে আমরা বলি ইন্টারনাল হার্নিয়া। এগুলি তাহলে মাথায় রাখবে। আচ্ছা, যাকে নেক্সট, আজকে তো আর বেশিক্ষণ পারবো না। আচ্ছা, নেক্সট যেটা আমি ওই ব্যাচে পড়েছিলাম, কারণ দেখলাম আজকে আরেকটা জিনিস ভেবেছিল কিডনি শুরু করবো, কিন্তু কিডনি আজকে শুরু করে লাভ নেই, কেমন? কালকে হবে। আজকে যেটা পড়া 10 মিনিটের টাইম আছে, 15 মিনিট কি ছেড়ে দিতে হবে। সেই দিন ক্লাসে বলেছিলাম রেকটাম অ্যানাল ক্যানেলের সবচেয়ে যেটা ইম্পর্টেন্ট পার্ট, ক্লিনিক্যালি ইম্পর্টেন্ট অলসো, তোমাদের যখন ডিওডিনাম এসে গেছে এবারে, there is a chance of question from the rectum and anal canal, abdomen. সুতরাং আমাদের একটা আইডিয়া থাকা উচিত। রেকটাম আমি প্রায় সবাইকেই বলেছিলাম এই ক্লাসে, আমরা জানি রেকটাম means straight, about 12 centimeter in length, and it has got curvature, anterior curvature and posterior curvature, known as sacral curvature and perineal curvature. Most important part. আচ্ছা, তার আগে একটু কথা বলি তোমাদের পেলভিক ডায়াফ্রাম। আমাদের এই নয় যে আমরা বোনস যেরকম দেখছি, ডিপ বোন বেশ খোলা ওপেন ঢুকে যাচ্ছে, উপর থেকে অ্যাবডোমেন একদম খোলা ঢুকে যাচ্ছে, তা নয়। As the thorax and the abdomen is separated by the diaphragm, similarly, abdomen proper and the pelvis, lower pelvis, is separated by like a diaphragm, a muscular partition, which is called the pelvic diaphragm. Come on, the pelvic diaphragm. এই pelvic brim-এর কাছে একটা এরকম diaphragm-এর মতো diaphragm রয়েছে, which separates the false pelvis or the abdominal cavity to the pelvic cavity. কে তৈরি করেছে? আমাদের thorax and abdomen তৈরি করেছে কে? the diaphragm, muscles, tendon, central tendon, পড়বে তোমরা, পড়েছো হয়তো diaphragm, সেটা করেছে the diaphragm. Similarly, it is also a fibromuscular structure. Mainly, it is formed by muscles. Two muscles, levator ani and coccygeus. Levator ani and coccygeus. What is the other name of the coccygeus? Ischio-coccygeus. So coccygeus hota, ischio-coccygeus hota. The most important, আমি ডিটেইলস পড়াবো না, তাহলে হবে না, শুধু একটা কথা জেনে রাখবে, এই যে levator ani, it is very important muscle. It is very important muscle. এই রকম রয়েছে, এরকম দোলনার মতো, এবং মাঝখানে there is a gap. In case of a male, there are two gaps, one for rectum and one for urethra. In female, there are three apertures, one for rectum, second for cervix and vagina, and third for urethra, যেখান দিয়ে পাস করে নিচে চলে যাচ্ছে and exposed to the exterior. A levator ani is not a single muscle like a তোমার অন্য মাসলের মতো, flexor digitorum, flexor brachialis, এগুলো মতো single muscle নয়. There are some strata, and these strata not in the same plane. Some উপরে রয়েছে, some একটু উপরে রয়েছে. So, levator ani is a muscle which is present in strata. এটা হচ্ছে ফিমেল। অ্যান্টেরিয়র হচ্ছে এইটা, যেদিকে ইউরেথ্রা থাকবে সেটা অ্যান্টেরিয়র, এটা হচ্ছে পস্টেরিয়র। এই লিভেটর অ্যানি মাসলটা হচ্ছে স্ট্রাটা, কেমন? আর পেছনে যেটা রয়েছে এইটা হচ্ছে কক্সিডিয়াস মাসল, আর পেছনের পাইরিফর্মে দেখা যাচ্ছে। আর সামনের এই যে এই উপরের এই জায়গাটা, এখান থেকে শুরু করে এইটাই হচ্ছে তোমার লিভেটর অ্যানি মাসল। Levator ani muscle, and levator ani muscle is composed of mainly two strata. আমি যদি দেখি, এটা anterior pubis, এটা হচ্ছে coccyx, কেমন? ভালো করে দেখো, আমি শুধু এলিভেটেড অ্যানি লিখেছি, এর পেছনে রয়েছে কক্সিডিয়াস। কক্সিডিয়াস আমি আঁকি, এই জায়গাটায় রয়েছে কক্সিডিয়াস মাসল, ইচ্ছে করে আঁকি। এইটাই হচ্ছে লিভেটেড অ্যানি মাসল। Levated and muscle consists of two parts, one anteriorly, one posteriorly. Anterior part এর নাম কি? Pubococcygeus. Pubococcygeus. আর posterior part of levated and এর নাম কি? Ileococcygeus. হিপোনের কি আছে? Pubic part, ilium and ischium. আর পেছনে যেটা মাসল রয়েছে ইসকিয়ামের কাছে পেছন দিকে রয়েছে বলে এটার নাম হিস্টোকক্সিডিয়াস। আমি আঁকিনি, বিকজ ইট ইজ নট এ পার্ট অফ লিভেটেড অ্যানাই। তাহলে দুটো পার্ট রয়েছে, একটা হচ্ছে পিউবোকক্সিডিয়াস, ইলিওকক্সিডিয়াস। ঝামেলা কি? দুটো জিনিস জানবে। ঠিক এইখানে একটা মাসল রয়েছে সাইডে, একটু হিপোনটা ভাবো, অবটুরেটর ফোরামে। এইখানটা রয়েছে অবটুরেটর ফোরামে, এইখানটা রয়েছে অবটুরেটর ফোরামে। অবটুরেটর ফোরামেনকে কোন মাসল কভার করে রাখে একদম? অবটুরেটর ইন্টারনাস। ভেতর দিকে অবটুরেটর ইন্টারনাস, বাইরে দিকে অবটুরেটর এক্সটার্নাস। তার মানে ইট ইজ কভার্ড বাই এ মাসল নোন অ্যাজ দা অবটুরেটর ইন্টারনাস। এদিকে অবটুরেটর ইন্টারনাস। The obturator internus is covered internally by a fascia known as the obturator fascia. যে কোনো মাসল fascia, এখানে pectoralis muscle, pectoral fascia, obturator muscle, obturator fascia. এই obturator fascia ঠিক মাঝামাঝি জায়গায় যে গ্রিন লাইনটা এঁকেছি, it gets thickened. obturator fasciaটা একটু thickened হয়ে গেছে, একটা দড়ির মতো হয়ে গেছে, like a rope, এবং সেইটার নাম হচ্ছে white line of the pelvis. white line of the pelvis, white line of the pelvis. Debate arises whether the white line is a part of obturator fascia or it is a part of levator ani. Recently it has been found that it is actually the anterior part, upper part is a part of levator ani and lower part is a part of obturator fascia. Details are covered. On the obturator fascia, there is a thickening extending from the pubic region to the এখানে রয়েছে ischial spine. এখানে রয়েছে একটা thickening রয়েছে, তাকে বলা হয় white line of the pelvis. Very important line. White line of the pelvis. Actually, again, so look, the pubococcygeus part, ভালো করে লক্ষ্য করো, takes origin from the posterior surface of the symphysis pubis, also from the anterior part of the white line. এটা হচ্ছে এদিকটা হচ্ছে origin, এদিকটা হচ্ছে insertion. এদিকটা হচ্ছে origin, এদিকটা হচ্ছে insertion. So pubococcygeus part takes origin from the posterior surface of the symphysis pubis. Symphysis pubis and also from the anterior part of the white line of the pelvis. হচ্ছে তো? Then it goes with around the rectum and urethra. This is the rectum, male রেখেছি. This is the urethra and form a sling-like structure known as the pubococcygeus. Right? সুতরাং pubococcygeus is a part of levator ani, anterior part. But bad luck কি আমাদের ক্ষেত্রে, it is again also have different strata. যদি posterior থেকে anterior part যাও, এইটুকুনি স্ট্রাটাটা বলে pubococcygeus proper. তারপরে রয়েছে puborectalis part which cover around the rectum. তারপরে puborectalis, তারপরে pubovesicalis. ডিটেইলস আর দরকার নেই, শুধু একটা নাম মনে রাখবে, the middle part of the pubococcygeus which encircle, এই নামটা মনে রাখবে, puborectalis. Puborectalis is a part of pubococcygeus. কেন পার্ট হলো স্যার? Pubococcidius again made up of a 4 strata, 4টে strata। ব্যাপারটা কি এইরকম? Pubococcidius এরকম নয়, আমি আঙুল দিয়ে বুঝাই তাহলে সুবিধা হবে। Pubococcidius একটা নয়, there are 4 strata। পেছনের স্ট্র্যাটার নাম Pubococcidius প্রপার, তারপরে স্ট্র্যাটাটার নাম হচ্ছে Puborectalis, তারপরে স্ট্র্যাটার নাম হচ্ছে Puboanalis, অ্যানাল ক্যানেলে যাবে, আর তারপরে নাম হচ্ছে Pubovesicalis। কেন? ব্লাডারে যায় বলে, ভেসিকল হচ্ছে ইউরিনারি ব্লাডার। তাহলে Puborectalis পার্ট হচ্ছে 4টে স্ট্র্যাটা, Pubococcidius হচ্ছে 4টে স্ট্র্যাটা নিয়ে আমাদের রয়েছে। কিছু পার্ট পস্টেরিয়র যায়, অত ডিটেইলস দরকার নেই। তাহলে এই রকম রয়েছে Pubococcidius দুপাশে, আর মধ্যখান দিয়ে রেকটাম, অ্যানাল ক্যানেল আর ইউরেথ্রা চলে গেছে। কেমন? অরিজিন কোথা থেকে নিয়েছে Pubococcidius? posterior surface of the sequoiasis pubis, anterior part of the white line। খুব ভালো কথা। তার মধ্যে কোনটা বেশি পড়বো আজকে এটা বলেই ছেড়ে দেবো, সেটা হচ্ছে Puborectalis part। Puborectalis part কেন পড়বো? কারণ এটাই আমাদেরকে, তোমরা যে বসে আছি আমরা সুন্দরভাবে, তার জন্যই পড়তে হবে। সেদিনও বলেছিলাম, বলে যদি Puborectalis part ড্যামেজ হয় তোমার যে কোনো মোমেন্টে আমাদের ডিফিকেশন হয়ে যাবে, একটুখানি রেকটাম এলেই হয়ে যাবে। কি করছে তাহলে Puborectalis part? আমি যদি স্যাজিটাল সেকশনে আঁকি তাহলে বুঝতে পারবো। এটা হচ্ছে পিউবিস, এটা হচ্ছে স্যাক্রাম, তারপর হচ্ছে কক্সিস, এইটা হচ্ছে রেকটাম। রেকটামের এইটা হচ্ছে স্যাক্রাল পার্ট, কনভেক্স অ্যান্টেরিয়রলি, তারপর হচ্ছে পেরিনিয়াল, সরি হ্যাঁ রেকটাম, কনকেভ অ্যান্টেরিয়রলি, তারপর হচ্ছে কনভেক্স অ্যান্টেরিয়রলি পেরিনিয়াল কার্ভ। এবং এই কার্ভটা থাকার জন্য হচ্ছে স্টুল আমাদের, এটা যদি স্ট্রেইট হয়, যখন আমরা ডিফিকেশন করি, ভালো করে এটা লক্ষ্য রাখো, যখন ডিফিকেশন করছি, we start in a proper position, in a adequate position, we want to defecate, কি হয় আমাদের এই জিনিসটা স্ট্রেইট হয়ে যায়, এই কার্ভেচারটা থাকে না, পেরিনিয়াল ছেড়ে দিচ্ছি, পেরিনিয়াল কার্ভ থাকে না, স্ট্রেইট হয়ে যায়, ফলে we easily স্টুল এখান দিয়ে বেরিয়ে যায়। কিন্তু নরমালি কেন থাকছে এবং আমাদের সোশ্যালটাকে রাখছে? A part of the Pubococcidius goes in this fashion from the pubis and wind round the এইরকম ভাবে টেনে ধরে রেখেছে, করে হয়ে গেছে বন্ধ, এই কার্ভেচারটাকে মেইনটেইন করছে। কেমন? সুতরাং যখন আমরা বসি আমাদের অর্ডার আসে, আমরা পিউবোরেক্টাল মাসলটাকে রিল্যাক্স করি, সোজা হয়ে যায়, ডিফিকেশন হয়। সো দিস ইজ দ্য ইম্পর্টেন্স অফ Puborectalis part। নেক্সট ক্লাসে হবে, কালকেই হবে। বুঝতে পেরেছো? শুধু পড়ার জন্য বললে হবে না।
We are going to discuss another important topic of lipid metabolism, that is lipoprotein metabolism. About the beta oxidation of fatty acid and ketogenesis. Okay? And today we are going to discuss the lipoprotein metabolism, which we already discussed in the lectures classes. Okay? What is lipoprotein? This is no group discussion. We discussed.
It is a form of transporter which transport lipid from one position to another in the body.
Anybody else? You give the answer. Answer. Be relaxed. I don't think you have not use for this. Give the answer if you have. What is lipoprotein? I always told you that you give the answer which is satisfactory for all the listeners. If I will ask you what is lipoprotein, then you will clearly tell, sir, it is a conjugated protein which is formed by the combination of lipid and proteins molecule. The function of this molecule is to transport cholesterol and triglyceride to different extrahepatic tissues. And one of the important molecules which also transport cholesterol from extrahepatic tissue to the liver for further metabolism. Understand? So this is the proper definition of lipoproteins. Now, on the basis of classification, how we classify the lipid molecules? How we classify the lipoprotein? Anybody else?
On the mechanical electrostatic movement.
Very good.
And sir,
Yes, on the basis of specific densimeter, on the basis of electrophoretic mobility. Okay. Now we divided our plasma protein into first one chylomicron, then HDL, LDL, IDL, VLDL, and lastly free fatty acids. Okay. So these are we can divide on the basis of the concentration of different lipid molecule fraction which is present inside the molecule of this lipoprotein. Okay. We classify them. But now we see the metabolism. That is very important. We discuss the point one by one. It contains peripheral lipoproteins, monolayer of amphipathic lipids, phospholipids, free cholesterol, cholesterol esters, and triglycerides. है ना? मतलब एक एसीटोन या कुछ कपड़ा लिखी साथ करो. ठीक है? So these are the general molecules. Understand? These are general molecules. Now you understand that whether I will tell you that LDL molecule contains cholesterol and take the cholesterol from the liver to extrahepatic tissues. Which one is extrahepatic tissues? Renal medulla, your muscles, your cardiac muscles, and all the muscles are what? All the tissues rather than liver is extrahepatic tissues. They take cholesterol either in the form of cholesterol esters. Okay, either in the form of cholesterol esters, they take cholesterol and store and these LDL molecule can take store in either in the extrahepatic tissues. LDL molecule, the function of the LDL, but the function of HDL is what? It takes the cholesterol from extrahepatic tissue to the liver for further metabolism. Okay. Now, this is basically, if we take the difference between all of these lipoprotein molecules, then you see here is the attachment of apoproteins. Apoproteins is what? It is a peripheral proteins. It is a peripheral protein. What is the function of this apoprotein? They can recognize the receptor first thing, and they also activate the enzymes and suppress the enzyme activities. Enhance the enzyme activity and suppress the enzyme activity. Which one is apoprotein? ApoB48, ApoA, ApoC, and ApoE. Okay? ApoB100, C and E. ApoB100, ApoA, ApoC, and ApoE. These are the class of protein which is attached at different lipoprotein molecules. So, okay. So this is the main discussion. Means these special class of protein are attached with the peripheral layer of this lipoprotein molecule, and on the basis of this special class of protein, we differentiate it. Okay. If the question is asking in the exam, write about lipoprotein metabolism. Write about lipoprotein metabolism. Then firstly you give the classification. Understand? What do you understand by that? Mode of metabolism, hydrolysis of lipoprotein lipase, hydrolysis of lipoprotein lipase. Here this lipoprotein lipase is present. Okay, in the peripheral tissues, okay, it's okay. But it is also present basically in the capillaries. Okay, attachment with the valve of the capillaries. What is the function of lipoprotein like this?
So to break down the
Just a minute. They are also all the students here. I know you know well, but try to give the chance to other students. They also give the answer. Yes. What is the function of lipoprotein like this? Huh? I don't know. It is a very perfect answer to all the exam. I don't know. मैंने नहीं पता मैंने क्या होता है. Why you don't know? All the things you know in the campus. What the food chart happen in the goal ghar you know. What is the menu of your mess you know. Lipoprotein lipase. Hydrolysis by lipoprotein lipase. Chylomicron. Okay. Here it is synthesized. It is synthesized in intestine, liver, plasma VLDL, liver and intestine. What is the meaning of chylomicron? What is the meaning of chylomicron? What is the meaning of chyle? It is a answer which? After don't wear this pajama in the next class. These are synthesized in intestine, liver, plasma VLDL, liver, intestines, and the chylomicrons mean it is secret. It is drained out in the blood from lymphatic vessels. Which vessels? Lymphatic vessels. That's why it is called chylomicron. Chyle means lymph. Okay. Now all these are the apolipoproteins. Major lipid content: dietary triglyceride, endogenous cholesterol ester, phospholipids. Here the word comes endogenous. What is the meaning of that? Endogenous. You want to? Yes. What is the meaning of endogenous triglyceride? This topic is already complete in the class. That's why I will ask your questions. हाँ तो बता दे. पीछे बैठ के घूमना रहा. बाद में भी क्लास से. Very good. Which are formed inside the body. What is dietary triglyceride? From outside. Can you tell me any kind of sources of triglyceride?
Sir, acetyl coenzyme.
Dietary source of triglyceride.
No, it's not that.
And acetyl CoA is what? It is other thing. Anybody else? Huh? हाँ, डालना घी जो खा रहे हैं, वो सब चार्ज ठीक है। अब देखिए, mode of catabolism. Hey students, listen. Mode of catabolism: receptor mediated endocytosis by liver and other tissues. Transfer of cholesterol esters to the LDL. This is the specific function of HDL. It transfers the cholesterol from liver to extrahepatic tissues. First thing, and LDL receptor mediates endocytosis by liver and other tissues. Now we see one by one all of these things. Metabolism of lipoproteins. The pathway of lipoprotein metabolism includes two cycles. One exogenous, second endogenous. These cycles are interconnected and both centered on the liver. Okay, so that means there is a one thing in which triglycerides are synthesized in our body. These lipoproteins are synthesized in our body. It is called endogenous. When we take this lipoprotein from our dietary sources, it is known as exogenous. Okay, you have to understand the both the terms. What the meaning of exogenous? What the meaning of endogenous? Okay. Now next one. This is exogenous pathway in which exogenous means dietary lipids are packed into chylomicron. Fatty acids from triglycerols of chylomicron are released by lipoprotein lipase to adipose and muscle tissue during transport through capillaries. Chylomicron remnant containing largely proteins and cholesterol are taken up by the liver. In the liver, the remnant release their cholesterol. Now, student, understand what is the meaning of that. Dietary lipids are package of chylomicron, that means it contains chylomicron. Okay, when it contact with the blood capillaries, when you taking the lipids, there the first process occurs is digestion and absorption of the lipid. Okay, digestion and absorption of the lipid. But you know, you will take the lipid, but lipid is a water insoluble molecule. Okay, so what happen? What happen first? It is comes in the small intestine, then there the action of esterification. Esterification, where the big molecules of the lipid are making the small molecules in droplets. Okay, which we call micelles. What we call micelles. Okay, these micelles when enter in the blood, then there is a presence of one enzyme. Which enzyme? Lipoprotein lipase. Which enzyme is that on it? Lipoprotein lipase, which is present in the blood capillaries, and these blood capillaries going to the muscles also in extrahepatic tissues. When these blood going to the muscles, they by the lipoprotein lipase, these lipoproteins molecule become breakdown by the lipolytic activity. Okay, when these molecules are breakdown, they can go into adipose tissue and muscle during transport through the capillaries. Chylomicron remnant contain largely proteins and cholesterol are taken up by the liver. In the liver, the remnant release their cholesterol there. They can synthesize other lipoproteins molecules. Okay. Now, the endogenous phospholipid synthesized or packed in the liver and delivered to the peripheral tissue by VLDL, removal of triglyceride from VLDL convert VLDL and VLDL remnant, it is called IDL. We already discussed that these points. No, why are you late?
So we have to go to the student. I do that.
Okay, you are going to student section. No problem. So, they are synthesized and packed the liver in the liver and delivered to peripheral tissue by VLDL. What is the meaning of that? Any students? What is the meaning of first point? Read it and clarify it. Madam, you clarify. Yes. What is the meaning of that? Can you listen the word nascent VLDL molecule? Nascent VLDL molecules. It is come from the intestine, then there is the formation of nascent VLDL. That means these molecules are not mature. Okay? So that is the meaning. There is packaging of this. Packaging means they contain cholesterol, they contain triglyceride in their molecular structure. Have you seen the structure of lipoproteins? They contain TG, they contain cholesterol and with the peripheral proteins. Okay, so that is the meaning of that. In the liver, the molecule become prepared in the form of nascent molecules. Okay, and removal of triglyceride from VLDL to convert VLDL remnant by IDL. Now we have already discussed that in the metabolic section. When there is formation of nascent molecule going to convert it into maturation. Maturation means they contain more apolipoprotein in their structure. Okay, they contain more apolipoprotein in their structure. By which molecule? By the HDL. HDL can give up their apoproteins molecules, and these apoproteins molecule attach with this VLDL molecules. Then it forms what? Then it forms mature molecules. समझने की कोशिश करिए. समझने का मतलब ये है कि VLDL molecule mature कब हो रहा है? VLDL molecule जब mature हो रहा है, जब उसमें सभी all the types of apolipoproteins are attached with that. अब सभी टाइप के apolipoprotein आप कहाँ से रहेंगे? That is important because HDL molecule don't donate their molecule to the VLDL. Okay, apolipoproteins को वो अपनी apolipoprotein देता है. इसमें sorry. VLDL को HDL अपनी apolipoprotein देता है, जिसके अटैचमेंट के बाद वो मॉलिक्यूल मैच्योर हो जाता है. एक बार मैच्योर हो गया, फिर वो क्या करेगा? Then it's going to the extrahepatic tissues. मैंने बताया था कि extrahepatic tissue पे जाएगा, वहाँ क्या होगा? अपने कोलेस्ट्रॉल को दे देगा. वहाँ पे भी क्योंकि extrahepatic tissue पे भी lipoprotein lipase है, वहाँ पे अपने molecule they can give up their cholesterol molecules from their structure, and after then if their 80% cholesterol molecule give up to this extrahepatic tissue and remnant will be called IDA. जो बचा हुआ जो होता है ना वो किसको क्या what we call IDA. This is called intermediate density lipoprotein. Okay. Now we understand with the diagram. You understand that this is the basic diagram of all this concept. That mainly it is synthesized in the intestines and there is a formation of chylomicron. Okay? Synthesized from the intestine in the liver, you will see synthesized first by the lipoprotein lipase which is present in the blood capillaries. You take picture, don't do it. If you want to take the picture, then it's okay. अगर कोई if lipoprotein lipase, then it forms chylomicron remnant. Okay? Because by the lipoprotein lipase, what happened? What happened with the lipoprotein lipase? What happened with the lipoprotein lipase? Lipoprotein lipase break down the molecules and convert this molecule up to free fatty acid. Convert this molecule up to free fatty acid. You will see the free fatty acid going to the peripheral tissues like adipose tissues for the storage. Okay? Now this is chylomicron remnant. Now this comes to the liver. It is comes to the liver and by the liver there these molecules form other molecules. It form HDL, it form LDL, it form IDL, it form LDL. Okay? Okay. This is a very perfect diagram. You will understand with the numbering of this given here. Anybody students can tell the number first. Which one is first? Synthesize. Okay? That means you will take the dietary lipid first, it going to the small intestine and there the formation of chylomicron molecule first. Okay? Now in the second step, there is absorption and it comes to the blood and these bloods going to the capillaries where lipoprotein lipase are present which convert this chylomicron molecule, triglyceride molecule up to free fatty acid. So these free fatty acid going to the peripheral tissues. Peripheral tissues means extrahepatic tissues, adipose tissues, muscles, renal medulla. Okay. Going further, this is second point. Now third point, it is called CMR. CMR stands for chylomicron remnant. Remnant means बचा हुआ, left out. ठीक है? वो chylomicron canister में कहाँ गया? Liver में. But it because these chylomicron molecules also contain some cholesterol. It contains also cholesterol in their structure. Now this is going to the liver. It also contains some triglyceride. So with these receptor molecules, they enter in the liver. They enter in the liver where they can degrade. What is the function of cholesterol? I think you already know how the cholesterol degraded. There is 3 degradation mode. First is formation of bile salts. Second one is formation of vitamin D. And third one is formation of steroid hormones. These are the degradation of cholesterol, in which these cholesterol become degraded. This in the fourth step, these cholesterol become degraded. Okay. Now here is over. Now there in the liver, there is another apoproteins are present. Where this apoproteins is synthesized? In the endoplasmic reticulum. Okay, so there is a formation of these VLDL molecules. It is called, we directly call this is mature VLDL molecule which contain some apolipoprotein which is further going on the absorption process. Where it is absorbed, it is going to the peripheral tissue. Just understand, it is a summarized form of lipoprotein molecule. You understand that these molecules, by the activity of lipoprotein lipase, what happens? They again break down. And here it is converted into free fatty acid, and these free fatty acid molecules are again stored in this adipose tissues. But again, the remnant molecule we called, बचा हुआ molecule क्या नाम है? Ideal. This is called intermediate lipoprotein molecule. Understand? So in the sixth step, there is lipoprotein lipase activity can break down this molecule and form an ideal. Okay. Now there is a fate of these ideal molecules in two ways. The first one, either it is going to the liver first, or it forms LDL. How it form LDL? How it form LDL? LDL is what? Low density lipoproteins. Okay, so it contains cholesterol. So either it is directly, this ideal molecule directly going to the liver for further metabolism, or it contains cholesterol, maximum amount of cholesterol it contains with different apoprotein molecules. Now these apoprotein molecules going to the peripheral tissues. See, these molecules going to the peripheral tissues first. So what happens in these peripheral tissues? They can store extra cholesterol. So that's why it is called bad cholesterol. That's why it is called bad cholesterol, because it provides cholesterol to the extrahepatic tissues like cardiac muscles and other muscles. Okay. यहाँ पे कोलेस्ट्रॉल की डेंसिटी बढ़ा रहा है और रेमिनेंट जो बचा हुआ कोलेस्ट्रॉल है वो डायरेक्टली लिवर में फर्दर मेटाबॉलिज्म के लिए ले जा रहा है. ठीक है. अभी यहाँ पे क्या होगा? It is providing the cholesterol in this peripheral tissues by the activity of this HDL, which is directly synthesized from this molecule HDL. This HDL can take this cholesterol molecule from this extra peripheral tissues and taking back to the liver for further metabolism. Okay, so HDL molecule can regulate the cholesterol level. So this is the summarized form of all this cholesterol metabolism. Now we will understand with this directly with this simple way. Here is L receptors, LDL receptor both are present, and here you see firstly we take dietary lipids, okay, which is comes to the small intestine. We take dietary lipid in the diet, which comes to the small intestine, and by the lymphatic vessels. That's why it is called chylomicron. By the lymphatic vessels, it going to their chylomicron. We call this chylomicron as a nascent. Why? It is new. And you will see in this structure, there is again different apoproteins are attached. ApoA, ApoB40. Okay? Now the next step, there is a maturation of this molecule. So where this molecule mature? In the next step. How it is mature? These molecules, these ApoC second, ApoB48, ApoA, ApoE proteins are attached with this chylomicron. Now it is mature. Student, okay. So now, because this is a very important topic, by the maturation molecules, again this mature molecule going to the formation of HDL molecule by forming attachment of these all these apoclass proteins. Okay, these apoproteins going to the next step further in the glycerol, it forms breakdown into glycerol and it goes to the liver in the extrahepatic tissues and further on. Have you any question regarding from this topic, this figure? अभी जब एक बार रीडिंग लगाएंगे ना, आप रूम पे जाएंगे एक बार खुद पढ़ेंगे, ये पूरी चीज समझ में आएगी, ऑल ऑफ यू अंडरस्टैंड कि मैं क्या कहना चाह रहा हूँ, क्या बताना चाह रहा हूँ, ठीक है? आपको ये पूरा क्लियर होगा। देखिए इसमें सारी जो चीजें हैं वो मेन चीज क्या है, ये कॉमन पाथवे है सभी lipoprotein metabolism का। These are the common pathway for all the lipoproteins metabolism. Now in the second, one student can describe this figure. Any students can describe this figure? It is metabolism of VLDL and LDL. कौन डिस्क्राइब करेगा इसको? ये तो डिस्कशन है, आज का कोई क्लास थोड़ी है, सब हम ही करेंगे। तुम करोगे? You will try? नहीं करना? पढ़ के आना चाहिए ना, बोला था कि पढ़ के आना है, पढ़ के आना है। Now you will see the first figure is liver, which contain glycerol free fatty acid, and by the esterification process it form triacyl glycerol. So what is in the triacyl glycerol molecules? TAG plus free fatty acid. When it is breakdown, it is firstly converted into DAG, this is diacyl glycerol, then it is converted into monocyl glycerol, then it is forming glycerol plus free fatty acid. Okay, and it contains cholesterol. So why these cholesterol molecules? They forming, first one is nascent VLDL. What is that? Nascent VLDL. You will see the number, it is 5, 6, 7. It is not come from this, it is come from this diagram. 4, it is up to 4. इसका नेक्स्ट डायग्राम है वो, ठीक है, कौन सा? ये वाला। From the fifth one, there is a formation of nascent VLDL. Nascent VLDL. Why I call nascent VLDL? Because it is not mature, it is a new molecule. By taking the apoprotein from these molecules, it becomes mature. Mature means attachment. Mature means attachment. Attachment of the protein. Okay? Now, by different activities, these can go into the fatty acid in by lipoprotein lipase basically in the adipose tissues. Adipose tissues. Okay? And by the lipoprotein lipase again activity, the glycerol is going to the liver for further formation of triacyl glycerol. Because this is repeating sequence in metabolic process. What is that? Repeating sequences metabolic process. What happens if the LDL, VLDL molecules is not formed? What happens? There is a one disease which is called, which we call fatty liver. Fatty liver is caused because the glycerol free fatty acid are not mobilized in the body and they can deposit in the liver, which causes fibrosis of the liver cells. Understand? Fibrosis of the liver cells. एक बार इस टॉपिक को ध्यान से पढ़िएगा, अगर आप जब तक पढ़ेंगे नहीं आपको समझ में नहीं आएगा. If you read this topic once a time, शांति से पढ़िए, आपको सब कुछ क्लियर हो, ठीक है, जो मैंने बताया वो सब क्लियर हो, ठीक है. Now there ideal molecule which is VLDL remnant going to the liver again for further metabolic process. Okay, but here you see that it forms LDL molecules and these LDL molecules can provide directly to the extrahepatic tissues where these LDL receptors are present. How these LDL receptors are recognized? How these LDL receptors are recognized? by a class of apoprotein which is present in this lipoproteins. This is ApoB40, ApoB100. Okay. So again, this is going to the peripheral tissues. In all the diagram, you will see that these lipoprotein molecules metabolize and then go to the extrahepatic tissues. Why go for extrahepatic tissues? For the cholesterol depositions. But there is only one molecule which can take the cholesterol from these extrahepatic tissues. That is HDL. Which one? HDL. Now LDL, because LDL is a bad cholesterol, it can form cells, means it can generate a process, it can be responsible for a disease called atherosclerosis. Which one? Atherosclerosis. Now metabolism of HDL. Here is HDL receptors are present. You will see again, there is again nascent HDL molecules are formed. First one, alkate, synthesizing. All this process is in a single diagram. You will see the number of all these diagrams. This is 9, 10. Means lipoprotein molecule are 4 types. And when the question is asking about lipoprotein molecules, how will you write it? कौन बताएगा कैसे लिखेगा इस क्वेश्चन को? How will you write it? This. Student, this is not an easy question. It is asking in your university exam in very long question. It is up to 10 to 15 marks. And whenever you write it, you can make the diagram first. Make the diagram, make the LDL molecule, make the VLDL molecules. और सबको बकायदा नंबरिंग देके उनको बताना है. ठीक है, तब आपको परफेक्ट नंबर मिलेंगे. अगर आपने नहीं बता पाया, then you will skip out. Same in the HDL molecules, where this hepatic lipase is present. Formation of firstly, HDL molecule is formed by phospholipid plus cholesterol. You will see the diagram. There is phospholipid plus cholesterol, which contain apoprotein A1, E, and C second. Okay. Now these molecules going to the next step. We call this molecule is maturation. So all these are the, you understand? आपको एक बार पढ़ना पड़ेगा. इसमें एक बार रीडिंग लगाइए आप जाके, तब आपको क्लियर होगा. ठीक है? HDL वाले में ये सभी रिसेप्टर्स हैं. SRB1 are the receptors. ABC. ठीक है? It is anti-binding cassette receptors, I think. Anti-binding receptors. And there is a one important properties of HDL. It is called reverse transport cholesterol metabolism. If the question is asking what the meaning of that, why are you putting this? Why LDL is a good cholesterol and LDL is a bad cholesterol and HDL is a good cholesterol. Why? Then you will write this concept, reverse transport cholesterol metabolism. Okay, ये आपका क्वेश्चन आएगा. Definitely उसमें आपको ये लिखना पड़ेगा. This is the process where excess cholesterol contained in extrahepatic tissue is taken up by the liver by HDL for utilization and excretion to the while the alkate acidifies this cholesterol. Okay, lecithin cholesterol is transferase. Contain HDL and prevent it from re-entering the cell. This acidification by alkate serves as a trap cholesterol within the lipoprotein cholesterol from deposition in the tissue. So ultimately, what is that? What is happening here? They can control the level of the cholesterols in the blood. How it is controlled? It is taken up by the extrahepatic tissues. Okay, and there alkate is present. Alkate is like a gate. एक बार cholesterol HDL में आ गया तो फिर वो दोबारा बाहर नहीं जाएगा. ठीक है? Alkate is a gate which can trap the cholesterol molecules. Okay, it can trap the cholesterol molecules. So it make the process of reverse transport cholesterol metabolism. How it is reverse? Because LDL molecule, all the chylomicron molecules, all the LDL molecule, what they do? They can take the cholesterol from the liver and take deposition in the extrahepatic tissues. But only HDL molecule can do. They can take the cholesterol from extrahepatic tissues to the liver. What is the significance of cholesterol, reverse transport cholesterol system? Nothing. It can reduce the risk of coronary artery disease. You ultimately know. आपको समझ में आ रहा होगा, इसमें कोई इसमें समझाने वाली बात नहीं है. जब आपका कोलेस्ट्रॉल लेवल लो रहेगा तो देयर इज नो चांसेस ऑफ एनी काइंड ऑफ CST, coronary artery disease, coronary artery disease, coronary heart disease, is any kind of myocardial infarction. Okay, so it is anti-atherogenic. Anti-atherogenic means what? What is the meaning of anti-atherogenic? First you understand atherogenic. Atherogenic means the substance which can make the blood vessel hardening. Hardening means deposition of the cholesterol in the inside the blood vessels. And the substance which can prevent the blood vessel to become hardening is called anti-atherogenic. So which one is anti-atherogenic? HDL. Okay. Now significance of reverse cholesterol transfer system. ये तो हो गया, ये भी हो गया. Diagnosis is important, nothing is important. LDL cholesterol is a bad cholesterol because it excess cholesterol presents the form of LDL. HDL cholesterol is a good cholesterol. Why? अभी बताया ना?
चलता नहीं है.
वो तो एक पॉइंट है, दूसरा पॉइंट क्या है? हाँ? कौन बताएगा इसका आंसर? तुम बताओ.
सर पेरिफेरल टिश्यू से जो कोलेस्ट्रॉल है उसको लेकर.
वेरी गुड. दिस इज आंसर. ये तो बोल रहे हैं. नाउ डिसऑर्डर ऑफ लाइपोप्रोटीन मेटाबॉलिज्म. कौन से डिसऑर्डर हो सकते हैं? हाइपरलाइपोप्रोटीनीमिया, हाइपोलाइपोप्रोटीनीमिया, familial hypercholesterolemia. Okay, you understand the term hyperlipoproteinemia? That means the level of the lipoproteins in the blood is increased. Why it is increased? If there is any absence of particular enzymes, if there is absence of any kind of apoproteins, if the apoproteins are not formed properly, then these molecules become accumulate. Okay, first one is hyperlipoproteinemia. Are complex causes the different disease mechanisms that rise to similar lipid patterns in practice. Lipoprotein disorder are classified as follows. First one is primary hyperlipoproteinemia and secondary hyperlipoproteinemia when the disorder is manifested due to some other disease. And you understand that these all are the types of hyperlipoproteinemia. You all of you take the pic of this slide because this is important. We perform this different types of lipoproteins. It is type 1, type 2, type B, type 3, type 4. ठीक है, ये सब आपको पढ़ना है तो उसमें आपको पता पड़ेगा कि कौन सा इम्पोर्टेंट है कौन सा नहीं. This is genetic type of hyperlipoproteinemia. दिया है आपके बुक में, already given in the book. और if you want to take the book, you will take the Harper book. Harper में सब दिया हुआ है. Harper नहीं पढ़ना है, DM वासुदेवन पढ़ लेना. DM वासुदेवन नहीं पढ़ना है, सत्यनारायण पढ़ लेना. पढ़ के अच्छी तरह कंसेप्ट बिल्ड करो अपना. ठीक है, मेकिंग योर ऑन नोट्स. नोट्स बनाइए और पढ़िए. कौन कौन लोग नोट्स बना रहे हैं आप में से? Raise your hands to those who make the notes. Now this is the things which we discussed today. That is lipoprotein metabolism. I summarize this. You understand? You listen carefully. We have different types of lipoprotein molecules. It is chylomicron, IDL, HDL, VLDL, and LDL. Okay, which have different functions. The major function of this lipoprotein molecule is to carry out some special cholesterol and triglyceride molecules through the blood to extrahepatic tissues. First one. Okay, but there is the one molecule called HDL which can do reverse transport cholesterol metabolism process. Due to this, it can reduce the chances of heart attack. It will reduce the chances of coronary artery disease. Okay, if we talk about the metabolism, then there in the if we take the lipid molecule in the dietary form, then it's firstly come into the small intestines, and in the small intestines they by the bile By salt activity, it forms measles and it can absorb it. And by endoplasmic reticulum, basically endoplasmic reticulum is nothing to do, but it can form a special class of proteins, which we call apoproteins. And these apoproteins are attached with these molecules, and they make a special class of lipoproteins. And all the lipoproteins having different class of apoproteins here. Okay? And further on, they can synthesize by different mainly 4 processes. The first one is formation of nascent molecule, second one is maturation, third one is absorption, and fourth one is uptake by the liver. This is the 4 step which is followed in all types of lipoprotein metabolism. Understand? The first one is formation of nascent molecule, means formation of a new molecule. Second one is maturation. Maturation, you know, attachment of different class of proteins, all class of proteins. Third one is absorption. Utilization. Utilization means it goes to the extrahepatic tissues where hepatic lipids are present. They can break down this molecule, and maximum amount of cholesterol is taken up by extrahepatic tissues. And other molecule we call remnant molecule. उसके बाद जो बचता है वो क्या होता है? Remnant molecule, which is 30% of mature molecule. Then it goes to the liver. There uptake process होता है. Okay? तो ये मेन 4 स्टेप हैं. ये सभी स्टेप सारे लाइपोप्रोटीन मेटाबॉलिज्म में कंसर्न करेंगे. इनको आप एक बार पढ़िए, इनका डायग्राम बना के अच्छी तरह समझिए, इनको रट लीजिए पूरी तरीके से, आपको क्लियर हो जाएगा. इसका लॉन्ग आंसर क्वेश्चन आता है 15 नंबर का, 10 नंबर का, वो आपका तैयार है. शॉर्ट भी आते हैं इसमें से. राइट अबाउट एसडीएल, व्हाट इज काइलोमाइक्रोन, व्हाट इज बीएलडीएल, ओके, व्हाट इज व्हाई इट इज कॉल्ड एंटी एथ्रोजेनिक. दिस क्वेश्चन कम्स इन योर एग्जाम. व्हाई इट इज कॉल्ड एंटी एथ्रोजेनिक. ओके, for HDL is the good cholesterol, VLDL is the bad cholesterol, LDL is the bad cholesterol. Why? All these statements are given in this topic. You read well, you understand well. If you have any queries, you will ask me. Okay? Thank you. If you understand, as clarified that atherosclerosis means hardening of the arteries due to the formation of plaque result in endothelial damage and narrowing the lumen. Basically a diagram which is happen when we have high cholesterol level in the blood. We have high cholesterol level in the blood. There is atherosclerosis occur, forming of a plaque. If this plaque is formed, what happens? Okay, there is increase of blood pressure. Okay, the cardiac muscle become ischemic. Ischemic means feeling less of oxygen, less of nutrients. Yes, sir. There is chance of myocardial infarction. What is the meaning of myocardial infarction? Infarction means lack of blood supply. Lack of blood supply, lack of oxygen. Okay, so these muscles not doing properly work, and there is a separate pain. We call this pain as angina. Okay. And these are the causes of development of atherosclerosis. These all are the causes: lipoprotein metabolism, level of HDL, diabetes mellitus, and other all diseases. Okay. So how will you manage and this from? कैसे मैनेज करेंगे ऐसे पेशेंट्स को?
Statin.
Very good. स्टैटिन देंगे. ऐसे स्टैटिन क्या करता है? कैसे करें? Very good. You will ask the question. You will ask the question that you will give the statins. What is the function of statins? This can inhibit an enzyme which we call HMG-CoA reductase. It is present in the cholesterol metabolism. They can bind with the HMG-CoA reductase and cholesterol is not formed in the body. First thing. Second and important thing is you suggest the patient to dietary control plus exercise. Dietary control plus exercise regularly. These are the drugs, lavostatin, clofebrate, and all these are the drugs which is inhibit cholesterol synthesis. Okay?
Rectum. Okay. So about the rectum, for initially it is the last part of the large intestine. Okay. So larger intestine continues as 1 to 75 here. See how does it look like? It is always remember it is misnomer. Okay. Why I said? Because rectum means where? Rectum means straight. Where else you get rectum? আমি বলেছিলাম এর আগের দিন রেক্টার কোথায় পাবি? কিডনি যে আছে না, কিডনি যেটা glomerulorenal circulatory system, there you get vasa recta. Okay, so whenever you are getting this term recta, recta means straight, but why it is misnomer, that is the rectum. Okay, so for knowing the rectum you have to know what are the different type of relation. Okay, so both in the case of male and female. Last page. Okay, so see the rectum has what are the three characteristics that it is devoid of. Characteristic of large intestine. The rectum is devoid of three. Number one, that is obstruction. Okay. Okay, and the third one, what is the third characteristic of large intestine? Architecture. Another one is tinea coli, right? So these are devoid in rectum. So these rectum, these are devoid of these all characters. Okay. And how does it look like? কিরকম দেখতে হয় rectum? Okay, so rectum is looking like that. Okay, and this is the initial part. It will start from the sigmoid colon. Okay, so in the rectum, these characteristics are absent. Okay, in the large intestine. Then next is what are the peritoneal relation. Okay, so could you tell me what are the relation in male and female peritoneal relation of rectum? বল কি কি থাকবে in case of male? কি বলছিস? তুই যেন লাস্টে বলে দিলি। প্রথমে suppose if you are taking one cross section by the abdomen, right? So first structure you will see where on the first thing, that is the umbilicus. Okay, afterwards which structure would be there? Next which structure would be there? Just have the cross section. Okay, from anterior to posterior. Rectum is present where on the posterior side, right? So if you take the cross section, what are the things you get? What are the characteristics it has got? So about knowing the rectum, you have to know what are the internal musculature. Means what are the internal structure present in the rectum. Write it down. Rectum has got three type of valves. Rectum has got three type of valves. They are anterior lateral, middle lateral, and posterior lateral. Okay, anterior lateral, middle lateral, and posterior lateral. So about the anterior lateral, see this is the internal structure of rectum. So it has got three valves. Number one, here would be one valve that is known as anterior lateral. Okay, on the midline it has got middle lateral, and here it has got posterior lateral, right? So it has got how many curvature? This is about the valve. Valve means it will prevent the backflow. Okay, so how many curvatures are there? Write it down. There are total 4 curvatures. That are total 4 curvatures that are present inside the rectum. They are so total 4 curvatures are there. Okay, among that in the midline there is one constant curvature. So suppose this is one kind of elevation present on the middle side and this is the constant. So remember this shape is maintained by this constant curvature. Okay, this is constant means this curvature won't get dismissed. Okay, it will be always present on the wall. Okay, it won't converge along with the wall of the rectum. Remaining all curvature becomes straight. I told rectum is a misnomer, right? It is looking like a curve. So when it will become straight, কখন straight হবে? বল? During the time of defecation. Okay, so among them, which curvature is always constant? Remember the middle curvature. Middle curvature is always present. Okay, means throughout the whole time the middle curvature is always present. Okay. So now next about the arterial supply. Okay, about the arterial supply of rectum. So rectum has got how many arteries? Who will tell me? 3 arteries. Very good. Which are they? Superior rectal, inferior rectal and middle rectal. So what about the blood supply, from where it is coming? These are the 3 arteries that will supply the rectum. So superior rectal is a branch of, very good, inferior mesenteric artery. Tell me the other branches. আর কি branch আছে? inferior mesenteric কি branch আছে? কি branch আছে আর? Inferior mesenteric. Okay, inferior mesenteric, that means it is the artery of hindgut, right? So hindgut it would be supplied by which artery? কি কি artery দ্বারা supply হয়? Ileocolic হবে না? Left colic. Number 1 artery is the left colic. Second one is the sigmoidal artery. Second one is the, if you could remember the sig, which are the part? We are having the lateral 1/3 of transverse colon, right? Sigmoid colon and then the rectum and anal canal, right? Then I told you this left colic will supply this lateral part of left lateral part of transverse colon along with the sigmoid colon. Okay? Then this rectum and anal canal will be supplied by this superior rectal artery. Okay? So the first branch is, write it down in bracket. Superior rectal artery is a branch of inferior mesenteric artery. Then what about by middle rectal? Middle rectal, write it down, middle rectal is a branch of portal circulation. Middle rectal, that's why I am asking whether portal circulation has been taught to you. So you are aware now what are the portosystemic anastomosis. So where is the places we are having portosystemic anastomosis? কোথায় কোথায় আছে? Who will tell? কোথায় কোথায় আছে portosystemic anastomosis? Ball, umbilicus is one of the answer. Are lower part of esophagus are arekta main. There are total 6 portosystemic anastomosis. Portosystemic means here is the anastomosis between the systemic vein with the portal vein. Okay, and these are the common site of hemorrhage, any type of hemorrhage. The lower end of esophagus, if anything happened in the portosystemic anastomosis, means if the portal hypertension. Okay, if there is raised portal vein pressure, what will happen? There will be bleeding. Okay, bleeding coming through the vomiting. Okay, so it is known as hemoptysis. It is known as hemoptysis. That is due to lower esophageal junction. Okay, then second one is at the umbilicus, that is known as caput medusae. Okay, have you heard of caput medusae? Means see, umbilicus is like a sun. Okay, and all the rays would be going throughout the abdomen. Okay, so the veins would be looking like that from throughout the umbilicus. Okay, today read this one. What is caput medusae? Okay, but it is not comparative study with the sun or sunrise or sunray like that. main thing, caput medusae is the thing one of the lady they used to keep on the bun. Okay, it's a kind of hair pin. Okay, so that's why the name came over, that is known as caput medusae. Then the third point, that is known as hemorrhoids. Okay, so these hemorrhoids we are concerned about the middle rectum. Okay, so middle rectal is a part of the total circulation. What about the inferior rectal? ওইখানে কি আর্টারি আছে বল? পেলভিক ব্রিমে কমন ইলিয়াক থেকে the external or internal iliac figure, right? So it is a part of internal iliac. Write it down. So inferior rectal artery is a part of internal iliac artery. Okay. Then next is about the development. Next is about the development of the rectum. Okay. Okay, so see, write it down. Development of rectum. Rectum develops from the circulation of hindgut. Rectum develops from the circulation of the hindgut, because you know it is also a part of hindgut. Hindgut starts from where? The left lateral part of transverse colon up to the anal canal. So here, knowing the development of rectum, you know in front of rectum which are the organ. Just think about that in case of male and female. Male কি থাকবে বল? পিছনে থাকবে rectum, right? Then next one is next থাকবে urinary bladder, and in between there is prostate. Okay, but in case of female মাঝে কি থাকবে? Uterus. Okay, so write it down. What are the peritoneal relation of rectum? Okay, so what are the peritoneal relation of rectum? So always remember, rectum is a retroperitoneal organ. Always remember, rectum is a retroperitoneal organ. So from posterior to anterior, make one arrow. From posterior to anterior, it is related to okay. Your posterior to anterior, it is related to so many structure is there. Okay. Number one, tell me the bony relation on the posterior side. Which part of sacrum? Here the question is, how many vertebrae are there in the sacrum? S1 to S5. Among them, S3 থেকে আসবে. Okay, so it is related to number one হচ্ছে S3 to S5. Okay, second one would be coccyx. Okay, then third one would be কোন arteryটা is the posterior division of abdominal aorta, যেটা স্যাক্রামের উপর দিয়ে রান করে. Very good. Median sacral artery. So how many arteries are there in the abdominal aorta? If we say the ventral arteries, just recapitulate কি কি artery আছে বল ventrally? Celiac trunk, then superior mesenteric artery, inferior mesenteric artery. What about the lateral? কি কি? তিনটে অর্গান আছে. অলওয়েজ রিমেম্বার, ল্যাটারাল অ্যাবডোমিনাল aorta এইভাবে যাচ্ছে along with the inferior vena cava. ল্যাটারাল সাইডে কি কি অর্গান পড়বে? There would be suprarenal gland, there would be kidney, and there would be gonads. So these are the three arteries. So there would be the renal arteries, the suprarenal arteries, and the gonadal arteries. So these are the lateral branch. Then what about the posterior branch? Posterior একটাই branch থাকে যেটাকে বলছে median sacral artery. Then again coming, what about the terminal branch? Terminal মানে শেষ ব্রাঞ্চ। কি কি শেষ ব্রাঞ্চ বল? The internal iliac or external iliac. Common iliac ke bhangche, then again the internal iliac and external iliac. Internal iliac kaake debe? All the intra-abdominal viscera. Okay, along with the pelvis. External iliac thale kaake debe? Already you studied. Pie is a lower limb. Okay, femoral artery is a branch of external iliac artery. Now if I will ask you, tell me uterine artery is a branch of internal iliac. ঠিক আছে, ইউটেরাইন আর্টারিটা কার ব্রাঞ্চ হচ্ছে? ইন্টারনাল ইলিয়াক। তুমি রেকটাম কে ওকে দেবে ইন্টারনাল ইলিয়াক, কিন্তু কোন রেকটাল আর্টারি? ইনফিরিয়র রেকটাল আর্টারি। তাহলে রেকটামে যে তিনটে ব্লাড সাপ্লাই পেলাম, তিনটে জায়গা থেকে এলো। একটা হচ্ছে ইনফিরিয়র মেসেন্ট্রিক আর্টারি, একটা হচ্ছে পোর্টাল সার্কুলেশন, আরেকটা কোথা থেকে আসবে? দ্যাট ইজ সিস্টেমিক সার্কুলেশন, ইন্টারনাল ইলিয়াক, দ্যাট ইজ কামিং ফ্রম পেলভিস। Okay, so second one is the median sacral artery. Third one, okay. Fourth one, write it down, sympathetic chain. Fourth structure. So this one, next one is median ektai ache, that is found above the sacrum. Okay, then fourth structure would be sympathetic chain. Okay, then what are the muscle it is related to? Kiki muscle ache at the posterior side, write it down. There are three muscle. Number one, levator ani. Number one is levator ani. Then next muscle is puborectalis. Okay, and the third one is coccygeus. Okay, so these are the three arteries, so three muscles. Okay, number one is levator ani, then second one is puborectalis, and the third one is coccygeus. So these two, see, coccygeus is present where? Just beside the bone coccyx. Okay, but these two muscles, one is levator ani and puborectalis, these are making the sphincter. Okay, so in the rectum, how many sphincter are there? Rectum e kono sphincter thake ki? Kothay thake? How many are there? One is external anal sphincter, another one is internal anal sphincter. So now the external anal sphincter would be formed by this puborectalis. Okay, and the internal would be formed by the levator ani. Okay, so these are the muscles that are making this anal sphincter. Okay, so this is about the structure present on the posterior side. Okay, so posterior side is covered. Then next one is after the rectum, in front which structure is there in case of female? Uterus is there. So remember, between uterus and rectum there is one space. এই স্পেসটাকে কি বলে? Just now you uttered pouch of Douglas, POD. ঠিক আছে, যখনই কোনো পেশেন্টের ইউএসজি করবি, ইউএসজি তে দেখবি হোল অ্যাবডোমেন ইউএসজি করেছিস কোনো ফিমেলের, নিচে nothing found in the pouch of Douglas. বা দিল mild collection in the pouch of Douglas. So pouch of Douglas is very important. Just make a start. Pouch of Douglas is the most dependent pouch. Most dependent pouch. Dependent মানে most depend. Okay. সবথেকে deep pouch. Okay. In case of female. মানে any connection in female uterus or urinary bladder, anything it will collect where? In the pouch of Douglas. Basically in the uterus. ঠিক আছে? যদি ধর কারোর ইউটেরাসে কোনো এক্সট্রা ব্লিডিং হয় বা কোনো ইনফেকশন থাকে, কোথায় কালেক্ট হবে? পাউচ অফ Douglas. Okay, then the next structure is in case of female we are talking. Okay, so female का पहले क्या हुआ? rectum, then you have uterus, in between recto-uterine pouch, then next this side which structure is there? Bladder, urinary bladder. So between urinary bladder and this uterus, is there any pouch? Again there is a formation of pouch. Okay, it is known as uterovesical pouch. Okay, write it down, uterovesical pouch. Vesicle. Vesicle means bladder. Urinary bladder এর আরেকটা নাম হচ্ছে vesicle. ঠিক আছে? So see, in case of female, how does it look like? প্রথমে umbilicus থাকবে, then suppose this is a urinary bladder and this is a uterus. Okay, so if this one is the urinary bladder, this one is the uterus, and this one is the rectum. So this pouch is known as pouch of Douglas. Okay, and this pouch is known as uterovesical pouch. Okay, so this is the peritoneal relation in female. Okay, number one at the urinary bladder after the umbilicus. Okay, then you are getting one pouch that is known as uterovesical pouch. Then we have uterus. Back of that again another pouch that is known as pouch of Douglas. Then at last there is rectum. Okay, but always remember in case of female this pouch is very significant. That is pouch of Douglas. But in case of male, what about in case of male? কি কি পাউচ হবে বল? একটাই পাউচ হবে, সেটা কি? সামনে আছে urinary bladder, পিছনে আছে rectum. So in between which structure is there? That is known as rectovesical pouch. তার মানে আমরা যদি বলি rectovesical pouch in female, it is wrong. There is nothing such. Okay, so write it down in case of male. In case of male কি হচ্ছে উপর থেকে urinary bladder. Okay, so after urinary bladder যে স্ট্রাকচারটা নিচে যাচ্ছে সেটা নাম কি? urethra, right? So from here you know there is some walnut like structure that is nothing but কি organ ওটা? prostate. Okay, so from prostate again here there is another structure that is going through, that is known as vas deferens. Okay, so you have to know that this is the structure, anteriorly it is present. Okay, and posteriorly which structure is there? Rectum. Okay, rectum will be present over here. So we have to know what is the level from where this rectum is combined along with the anal canal. Okay, for that thing you have to know its connect from where the apex of the prostate finished. ঠিক আছে, যেখানে apex of prostate টা finish হচ্ছে, that is the junction of the rectum and anal canal. So write it down. In case of male, where the apex of the prostate completed at the same level of the junction between the rectum and anal canal. Understood? So both are at the same level. Okay, and এই লেভেলে কি থাকছে? এই লেভেলে one muscle very important, that is known as puborectalis. So where it is present? Puborectalis, where it is present? It is present between the junction of rectum and anal canal. Okay, it is making the flow between the rectum see the anal canal, there is one term known as pectinate line. So what is the pectinate line, do you know? Already we have studied in the lower limb. So these pectinate line correspond the junction between internal and external anal sphincter. Write it down. The pectinate line correspond to the junction between the internal and external anal sphincter. এই রেক্টামটাই এখানে কন্টিনিউ হচ্ছে, that is known as anal canal, and in this anal canal there is a several mucosal fold. যেটাকে আমরা কি বলছি? pectinate line. So this is known as pectinate line. Okay, so next we will already discuss about the arterial supply of rectum. Now write it down, the venous drainage. The venous drainage of rectum. So same like the artery, it has got the superior rectal vein, the middle rectal vein and the inferior rectal vein, and it will correspond the inferior mesenteric vein, okay, and the portal vein and internal vein. Understood? So these arterial supply is very much simple, arterial and venous drainage. Okay. Then what is hemorrhoids? What do you mean by hemorrhoids? Don't laugh. Okay, it's for layman. Being a doctor, you are not allowed to laugh. Okay, go. Medial sacral vein, হ্যাঁ, তিনটে vein থাকে, একটা হচ্ছে superior rectal, middle rectal, inferior rectal. So what is happening? What is the source of bleeding? Hemorrhoid এর bleeding টা হয়, কোথা থেকে bleeding হয়? Is it origin from venous or arterial? Venous হবে, always remember. Okay, hemorrhoid এর যে bleeding টা হয়, source is venous bleed. Okay, you could also write it down. The source of bleeding in hemorrhoids. Layman क्या बोलेगा? Piles. Okay, piles or hemorrhoids. So the source of bleeding in the hemorrhoids, এটা কিন্তু MCQ আছে. Okay, it is from the venous source. That means the inferior and middle rectal vein. Superior rectal টা আসে না, কারণ the middle and inferior rectal vein supply করে কাকে? pectinate lines. ঠিক আছে? And according to that, these hemorrhoids differentiate. একটা superior থেকে হবে, একটা inferior. Okay. Now write it down about the lymphatic drainage. Of rectum. Okay. So rectum এ কি কি lymphatic drainage হতে পারে? Just think about that. क्या बोलो? lymphatic drainage. Rectum है, right? Rectum is the last part of large intestine. So इसका lymphatic drainage क्या हो सकता है? बोल। और ऊपरे কি আছে? Above rectum which structure is there? Sigmoid colon. So there is sigmoid lymph nodes. Number 1 is sigmoid lymph nodes. Then there is between the rectum and the anal canal, তাহলে সেখানে কি হবে? Anorectal lymph nodes. Sigmoidal lymph nodes, anorectal lymph nodes. Then there will be internal iliac lymph nodes. এবং you also know these are the structure. Which are the structure that would be covered by mesentery? Appendix এ থাকে We have studied appendix. Appendix এ থাকে mesentery. মেসোকোলন থাকে না, ট্রান্সভার্স কোলনে থাকে আর sigmoid কোলনে থাকে. Okay, so there is another type of lymph node that is known as mesenteric lymph node. So these are the 4 type of lymph nodes you will get in the rectum. There are 4 type of lymph nodes you will get on the rectum. Okay, so this is about the lymphatic drainage. Okay, so now write it down about the clinical anatomy. So what you have to study? So number 1 is about the hemorrhoids. Okay, then already I told this is one of the site for photosystemic anastomosis. Photosystemic anastomosis, one of the site for the photosystemic anastomosis. Okay, and the third is, this is you have to study from embryology book. Okay, so what is patent? What is patent? What is patent? Rectovesical duct. Rectovesical duct. Okay, so for that in the next class I will just have a discussion over the embryology specific. Okay, I will try to touch all the embryology of the GI. Okay, how each and every organ is developed in gist. Okay, for next class please study the anal canal tomorrow. Okay, tomorrow you have another class. Tomorrow we will finish all GI tract. From next one onwards we will study the pelvic organ. Okay, urinary bladder, then we have the uterus. Okay, and the prostate. So these are the organs we will study. So there is no such specimen of rectum. If you want to see, go to the cadaver. Okay, see from the cadaver how the last part of the sigmoid colon, then there is the rectum. Okay.